Symposium, which is being held in Lahore. I would also like to extend my great gratitude and thank you for the invited speakers who have taken their precious time to record the video lectures, and they will be joining us for the question and answer session, inshallah. So today's workshop is just like in the previous years, we have designed it. It will be a series of 1 hour long 4 lectures, followed by a brief session of question and answer session. Please write down your questions and send us via Zoom link, and we will be sharing those questions with the faculty at the end of the lecture. So without further ado, I will first invite my first speaker, and we will play her lecture on breast cytopathology. Her name is Dr. Anwar Raza Sultana, and she is very well recognized for her education and commitment to teaching. She's the person, on a personal note, she's a very humble person, and she is really good in teaching. And I have had the pleasure to attend her courses for board certification, and she really tries to come to the resident level and the faculty level and to teach them the basic as well as develop their concepts on the basic concepts, sorry. She is currently working as a professor of pathology and anatomy in Loma Linda University, California, USA. So we will play her lecture now, and I truly hope that your time spent here will be greatly rewarded. Thank you. So please continue.
Assalamu alaikum, everyone, and good morning. My name is Dr. Anwar Raza. I practice in Southern California, and I've been asked to present at the 23rd Shaukat Khanum Cancer Symposium, and my sincere thank you to the organizers for this kind invite, and in particular, Dr. Omer Sheikh. Due to some unforeseen circumstances, I'm sorry that I'm not able to join you in person, but let's see if we can still manage to have somewhat of an interactive session through Zoom presentation. So I was asked to give an update on breast cytopathology. Well, in 2005, my colleague and I wrote an obituary in diagnostic cytopathology, and the obituary was about FNA of the breast just not being performed as much because, everybody, the clinicians really wanted core needle biopsy because they would get more material, vacuum assisted as well, and they could do more testing on that. Currently here in the West, we're pretty much being asked to perform and interpret FNA of breast when the clinicians are quite confident that it's going to be something very benign, obvious benign, such as fibrocystic change, or they suspect a fibroadenoma, or if it's something that's where they know it's malignant, pretty advanced malignancy, and they just want confirmation before they can start treating the patient. A quick review of the anatomy of the breast. We have lesions that may occur more centrally or more peripherally. It's usually most of the breast diseases may tend to occur in these terminal duct lobular units. And when we go closer, you can see that these terminal duct lobular units have an inner epithelial layer with a surrounding contractile myoepithelial layer, and then basement membrane around that. And if we were to do an FNA and sort of put a needle through here, you would expect to see lots of these epithelial cells, which are seen here. But notice these sort of ovoid myoepithelial cells. They'll be either have a focus above or below. And many times on aspirates, you can see them as, sort of doublets, as you can see over here. And if you see both epithelial and myoepithelial cells, Sorry, I need to. So then you're pretty much convinced that it's going to be something benign. Here's a woman who presented with cyclical pain, and on examination, both breasts, one or both breasts had these lumpy, bumpy, sort of to palpation, and on aspiration, there was clear fluid with no residual mass. And on the aspirate, we noticed there was clear fluid, maybe some histiocytes, and sheets of these cells with granular cytoplasm. So this is apocrine change, and clinically, it fits with fibrocystic change. And you can reassure the patient. Sometimes the patient may have a history of recent surgery or trauma or a motor vehicle accident, and then subsequently, excuse me, there's sort of irregularity, maybe dimpling of the skin, and on fine needle aspiration, you would notice there'll be inflammatory cells, maybe some fat cells, different sizes, and over here you can see a multinucleated giant cell, and this would sort of confirm the clinical impression of a fat necrosis, but be careful, there may be fat necrosis adjacent to invasive tumor as well, so it has to be correlated with clinical findings and adequate sampling. This can be quite a pitfall. Here's an aspirate from a young woman. You may or may not be told that the woman just recently delivered and is actually breastfeeding. So this is lactational change. All these epithelial nuclei are very active with the prominent nucleoli, but notice the very bubbly background that you see over here. So this is lactational change, and that can be a pitfall unless you know that the woman is pregnant, and you have to think about it. The most common benign lesion in young women, fibrocystic change, and then the tumor you would expect would be a fibroadenoma. So fibroadenoma, so you have the epithelial component as well as the stromal component. On aspirates, you see a lot of these epithelial cells with accompanying myepithelial cells, and you may or may not see some of these stromal fragments. Another thing is the epithelial groups show this dichotomous branching. You can see them sort of branching here, branching here. When you go up and down, you can see lots of myepithelial cells with that. And here you can see a stromal fragment. So this is a classic fibroadenoma with this dichotomous branching, maybe some stromal component and accompanying myepithelial component as well. Another fibroepithelial lesion where you have both the epithelial component as well as the stromal component, but notice that the stromal component appears to be somewhat hypercellular. So you have fibroadenoma at one spectrum, at the other spectrum you have a phylloides tumor. These phylloides tumors tend to be in women a little bit older, maybe larger lesions, but not necessarily so. And you can only diagnose a phylloides tumor on needle biopsies or core biopsies or fine needle aspiration if you can see both the epithelial as well as the stromal component. And notice how cellular this stromal component is. And sometimes you can see frank malignant or sarcomatous change in the stromal component, as is seen over here. The most common malignancy in breast is, carcinoma of no special type, which is, sort of ductal adenocarcinoma. And notice you have these cells with a high nucleus to cytoplasmic ratio. They may appear somewhat plasmacytoid with the nucleus slightly away from the center. But what's missing? You don't see the myepithelial cell component with these, right? So this would be a classic fine needle aspirate of ductal adenocarcinoma of the breast. Here's another one showing high nucleus to cytoplasmic ratio, maybe prominent nucleoli, irregular chromatin, irregular sort of clumping next to the nuclear membranes, and pleomorphism, as you can see here. The next most common malignancy on the breast would be lobular carcinoma, and this can be deceptive. The cell size is usually smaller, and they tend to be small. And oftentimes it'll be sort of an irregularity, not necessarily a breast mass. And on fine needle aspiration, you may see these single cells that at low power look pretty much like lymphocytes, but when you go down, notice the intracytoplasmic lumina, and sometimes you may even see a mucin droplet in here. This is a high power showing here's one cell with two intracytoplasmic lumina with mucin droplets. Both ductal and lobular can give you this, but particularly in lobular. And these lobular tumors tend to line up in single files, almost like caterpillars on histology, and even with metastases in fluids, you may see these linear arrays. And lobular carcinoma is the one more likely to go to the cavities, more likely to metastasize to the GYN tract, as well as the CNS. Here's another breast aspirate, a woman in her 40s with sort of a irregular sort of finding on mammogram. So there was suspicious, and this was a fine needle aspirate of that mass. Notice you can see these single cells. They look pretty bland and small. And what's missing is you don't see the myepithelial cell component. And if you look carefully, notice this was almost forming a arrowhead. Sometimes you can see these pipe-like structures. And so it's very sort of low grade. Your differential would be, could this be lobular? A lot of people might say suspicious for malignancy, but this is supposed to be quite classic for tubular carcinoma of the breast. And a tubular carcinoma, we have these open gaping tubules with these apicorine snouts, and there's loss of the myepithelial cells in these. So a low-grade lesion with good prognosis. A woman may present with a circumscribed breast mass that feels soft to palpation, and they may do an aspirate or biopsy. And you can see these sheets of cells, but look what's in the background. You see blood, but lots and lots of mucin. This is an example of mucinous carcinoma of the breast. Okay, and on a pap stain, you can see these tumor cells floating and the background of mucin. So mucinous carcinoma of the breast, sometimes when you give the diagnosis as malignant, they would be rather surprised because it was very well circumscribed and felt soft, and they weren't expecting it to be malignant. Ductal carcinoma, it's very hard, feels gritty, and is irregular with dimpling. So this is mucinous carcinoma of the breast, and that's a histology of mucinous carcinoma of the breast. Here are the tumor cells. Notice the mucin in the background, and these have somewhat better prognosis than the carcinoma of no special type and even lobular carcinoma. Here's an FNA of another breast mass in a woman. Again, this was very well circumscribed, and the aspirate shows very, very ugly pleomorphic cells. So these are the tumor cells here with irregular chromatin. But notice there's also accompanying lymphocytes, maybe some plasma cells. So here again, another example of that, showing these very, very pleomorphic tumor cells, and notice the lymphocytes associated with that. This would be something that would be, it would say it's a carcinoma with medullary features. You cannot definitively say that on core biopsies or on fine needle aspirations, but you might add that in a comment. And these are so-called carcinomas with medullary features. They've been seen more often in patients who are BRCA1 carriers, patients with those mutations, and it's one of those triple negative tumors. Sometimes we'll get these nipple smears. The patient may present with a sort of crusting, weeping lesion in areolar lesion, and they may make a smear of that. And then these are the tumor cells, very high nucleus to cytoplasmic ratio. And this would be something they would see, Paget's disease of the breast, so mammary Paget's disease. Oftentimes, there's concomitant ductal in situ or invasive carcinoma in those patients. So there is a classification system for breast cytology. This is by the International Academy of Cytology, and this is to sort of uh, make it easy for the clinicians to know what the different cytopathologists mean, all over the country and all over the world. So you can either say it's insufficient, or it's you have a lesional tissue, but you favor benign, or atypical, you're not quite sure, suspicious for malignancy, or frankly malignant. And some people talk about, well, what about adequacy? You want to see sort of well visualize groups of cells, 4 to 6, or maybe 10 or more, um, actually 10 or more cells, and you want to see 4 to 6 clusters. But sometimes, even if you have less, if it's frankly malignant, it can be pretty diagnostic as well. So, of course, you have to correlate with the clinical as well as the imaging findings. Now, metaplastic carcinoma is another one of those triple negative tumors. You may see these very pleomorphic spindle cells. Sometimes you can see these squamous cells in that, and you would have to do the keratin stains to diagnose that. Now, squamous cells on Papa Nicolau staining, they have this orangeophilia in the cytoplasm, dark chromatin, and on a diff-quake, the color has been likened to robin's egg blue, almost like that Tiffany box color, a little sort of turquoise in some areas. This is just to remind everyone that in the breast, you can also have this tumor, a clue. This was an FNA of a breast tumor. This was also triple negative, ER, PR, and HER2 negative. But this one is very common in the salivary gland, so that's a clue for you. Small basaloid cells. Look at this basement membrane material in between. This is an example of adenoid cystic carcinoma of the breast. And unlike the head and neck, it's not as aggressive, but this is one of those triple negative primary breast tumors. What about this case? A 25-year-old sort of young lady presents with a breast mass that's growing quite rapidly, and there's obvious discoloration of the skin, and a fine needle aspirate was performed. So notice you have these sort of spindled nuclei, but also the background is quite bloody. So what would you think? And if you see the patient a week later, there's even more discoloration of the breast, and this is something that goes quite rapidly. This is the cell block, and this is an example of primary angiosarcoma of the breast. And you can do the vascular markers, CD31, CD34, as well as other vascular markers for angiosarcoma of the breast. They can be primary in young patients, but more often, fortunately, it's very aggressive. Fortunately, it's rare, but we are seeing these in older patients, particularly those who have been treated for breast cancer. In the past, it was secondary to chronic lymphedema when all the lymph nodes were being taken out and there was radiation. Nowadays, it's most commonly due to post-radiation. So post-radiation sarcoma, about 10 years or more after they were treated with radiation for breast carcinoma. Here's one of those quizzes that we received. Those of us who do cytopathology, we subscribe to various ASCP and CAP, quizzes in GYN, non-GYN, and surgical pathology. So this was one, and the only information we were told was this was from the breast. We just had a cell like this. Looks like the nucleus here, and maybe, something just pushing it away. All of us, except for one colleague, got this right. What they didn't tell us was that this was a skin-based lesion, and actually, it was just a molluscum body from a patient with molluscum contagiosum. That sort of dewdrop-like lesions that it can occur on the skin in crops. It's a viral infection. So before we move on, once again, recognize this is ductal adenocarcinoma of the breast on fine needle aspiration. You can see this. Maybe woman may have had a fracture of the femur, and you can see cells like this. And in a woman, always think about a metastatic breast carcinoma, and you would do, the appropriate stains to confirm that. Right. So let's move on. So that was a quick review of some cytopathology findings. So let's move on to some of our core needle biopsies and lumpectomies. So the first case, 84-year-old woman who presents with a left breast mass, and it was somewhat cystic. And so they went and did a core biopsy, and on core biopsy was pretty cellular. You can see these sort of slender capillaries and this proliferation of cells. And surrounding this, there seems to be a lot of this eosinophilic material, almost as if there's a capsule or an enlarged duct lining. Higher magnification showing these slender capillaries and these cells that are somewhat cuboidal or low columnar and quite uniform. In some areas, there may be some cribriforming as well. Another view showing these capillaries and these columnar or somewhat cuboidal cells. Mitotic figures are not readily appreciated. Okay. And so again, that's where the bulk of the tumor is. And then surrounding that, we could see this sort of eosinophilic collagenous stroma. And we see similar nests over here. But then further out, you just see normal breast tissue. So this is what you have. And so the first thing to think about, well, what is the most likely diagnosis? Would you favor it being adenomyoepithelioma, encapsulated papillary carcinoma, just invasive breast carcinoma of no special type? Could it be metastatic carcinoma or solid papillary carcinoma? Once more, let's look at the lesion. Here you can see the lesion, and here you can see the surrounding tissue. So this is an example of an encapsulated papillary carcinoma. It's seen in older women, centrally situated circumscribed mass. And oftentimes you can see this thick fibrous capsule surrounding these tumor cells. And it's papillary with these delicate, slender fronds and cuboidal to columnar cells, as you can see. And the atypia is pretty low grade, low to intermediate, and mitotic figures are not readily identified in classic EPC. Now, there's a thick surrounding capsule, but do not misinterpret these entrapped tumor cells as being evidence of invasion. For invasion, you want to see these further away from here, not just within the capsule itself. And sometimes there'll be complications because the patient may have had a core needle biopsy, in which case you might see a needle tract, with sort of seeding of that tract by these tumor cells. And at higher magnification, you can see, and you can also do stains, and there'll be absence of myepithelial cells in these cores and even at the periphery. However, the periphery, you can still see some basement membrane material and collagen. So what exactly is an encapsulated papillary carcinoma? The myepithelial cells are absent, but there's still a basement membrane there. So is it a variant of ductal carcinoma in situ, or is it on the spectrum from ductal carcinoma in situ becoming something, malignant and invasive? Maybe it's a tumor that has a very expansile growth pattern. Oftentimes, it's very circumscribed, and there's lack of axillary node metastases, but there are some cases where you can see axillary node metastases in cases of encapsulated papillary carcinoma. And when they put all of the tumor in, they still could not identify, frank invasion. The main thing is it's associated with an excellent prognosis, and the patient can be treated with local therapy alone. So for staging, it's staged as a ductal carcinoma in situ, except if they remember, in classic EPC, you should have low to intermediate grade nuclei. But if you have high grade features, it's best to call this as an invasive ductal carcinoma, no special type, and treat it as such. So the patient does need to have axillary node dissection. Now, those EPCs with obvious invasive carcinoma, it's usually a ductal no special type. Clearly beyond that fibrous capsule. On this, remember, only the size of the invasive component is used for T size for staging purposes, not the so-called encapsulated portion. So the treatment, it's treated similar to ductal carcinoma in situ, just excision alone. Some people, may debate, should we do a sentinel lymph node sampling and, hormone therapy in some cases, but chemotherapy is not indicated. Something very similar to an encapsulated papillary carcinoma. The other papillary lesion that you see in older women is a solid papillary carcinoma. This is also arises very centrally. And notice you can see some vessels here and very monotonous cells, and sometimes they may be spindled, almost streaming, so it looks like a usual ductal hyperplasia, except if you do stains, the myepithelial component is missing in the center of these. So this is also historically considered to be a variant of ductal carcinoma in situ. It's very indolent, and it has these circumscribed solid growth pattern. Unlike EPC, there's no fibrous capsule. It's very monomorphic and has the chromatin pattern and sort of resembles neuroendocrine, and it can even stain with the neuroendocrine markers. There may be some mucin production with this as well. And you may see scattered mitoses. And if you stain for the myepithelial markers, they're absent in the center of the proliferation, and even around the periphery, they're pretty much absent, but they, or if they're present, they will be incomplete. Again, it's postulated, is this a type of a low-grade carcinoma that sort of has expansile growth rather than just an in situ lesion. However, most of these have a very good prognosis. Again, there have been some case reports of metastatic foci that looks just like a solid papillary carcinoma. They've been mets to the lung, but it's infrequent. So when would it be a solid papillary carcinoma with definite invasion? If you see nests with irregular borders, sort of jigsaw-like, or geographic patterns, maybe desmoplastic sort of stromal response, and then those would be, it's better to call them as a breast carcinoma with solid papillary features. And if this uncertainty, whether it's in situ of this obvious invasion, it's better for staging and management purposes to classify these as in situ, because most of them have a very indolent course. Here is an FNA of a papillary tumor, and sometimes you can see columnar cells. But again, just like on core biopsies and FNA, you may suggest that it's a papillary lesion, but the best thing is to excise the lesions and then do stains and work up for precise classification. The other papillary tumor would be, benign papilloma, but in this, if you stain it up, you can see the capillaries, the fronds that twist and infarct, and there's usually a lot of bleeding through the nipples for that. But if you were to do stains, you would see both the myepithelial as well as the epithelial cell component. Adenomyoepithelioma is is a sort of intraductal papilloma in which both the epithelial and there's a very, very prominent myepithelial component. It can be very well circumscribed and also seen in older women. Sometimes these can be malignant, either the epithelial component or the myepithelial component, or both components may be malignant. What type of breast carcinoma is this one? You can see these clear spaces with sort of floating tumor nests in that. This is an example of micropapillary carcinoma. It can be pure, but more often it's with other types of breast carcinomas. And the stroma has this sort of spongy appearance. And when you look at that, almost it appears to be this sort of a central lumen formation. And the main thing is to identify these and note the percentage of tumor that has these features. And something that you can do to confirm that it's micropapillary. This one has inside out, it's a reverse polarity by EMA and a Mach stain. So it'll be staining on the outside of the nest rather than in the center. And the main thing is these patients very often have actually node metastases and have earlier recurrences. Okay, so the next case, we had this 55-year-old woman who presented with a breast mass, and a core biopsy was performed, and this is what we received. We could see a proliferation here, somewhat papillary, and then also this fibrous capsule around that. Another view showing this sort of fibrous capsule. You can see some tumor here, some tumor over here as well. And this is just showing the papillary nature. This is that thick capsule that's noted. Higher magnification showing these tumor cells. Mitotic figures were, quite readily identified. So on this case, number 2, what's your diagnosis? You can see these papillary features. So which one of these would you favor for this case? Could it be invasive breast carcinoma, no special type, then? So one of my colleagues did the myepithelial markers and they were absent. So just, staying with epithelial cells, and then the ER was positive. So it sort of looked like an encapsulated papillary carcinoma, but there was something a little different about it, and particularly the nuclear features were high grade. Well, then the clinician called, the patient went to tumor board and said, this patient has another tumor and in a different part of the body. Could this be a new primary in the breast, or is this metastatic disease? So the question is, what would you do next? Where do you think another tumor of the body would have features similar to papillary carcinoma of the breast? Obviously we would review the previous tumor and what stains would you do. One of the ones my colleague did was GATA3, and that was negative. So it wasn't staining like a breast cancer. Well, what we were told is that, hey, this patient has a high-grade ovarian serous carcinoma, and this is the ovarian tumor. Notice the psammoma bodies, and, here's the tumor itself, another view of the ovarian tumor. So the breast mass that we had, we did the stains, and PAX8 is positive, P53 and WT1, and it stains like an ovarian tumor. So this leads me to talk about metastases to the breast. It's rare, less than 2% of all breast cancers. Most of them are going to be primary. Oftentimes there's metastases from the contralateral breast. Patient has a carcinoma in one breast and it may spread through the lymphatics to the other breast. But, you can have various extramammary solid tumors with metastases to the breast. And Primary epithelial ovarian carcinomas are the commonest in women. The serous carcinoma, it can often present as a solitary mass, usually in the upper outer quadrant, or if there's massive tumor, even clinically as inflammatory breast carcinoma. And sometimes the breast mass may be the first manifestation of this ovarian disease, or, as in our case, the patient may have known ovarian carcinoma and been treated that. It can be months or years earlier and now presents with breast mets to the breast, or it may be concomitant where there's both, patient at the same time diagnosed with ovarian as well as breast cancer. So these mets from ovarian tumors, they can resemble solid papillary, even micropapillary carcinomas in the breast, and a lot of them present as a solitary nodule with a pseudo capsule, so and circumscribed growth pattern, and about a quarter of these without a history. The knee-jerk diagnosis would be, oh, it's another, that this is just breast carcinoma, with papillary features, a type of papillary carcinoma. And if you were to do stains, these mets from the ovary would also be CK7 positive, often ER, PR positive, and even this new breast markers, 10 to 15% of them can be positive. So it's important to distinguish primary versus metastatic tumors. And you can do stains, CA125, WT1, and PAX8 would stain ovarian tumors. Breast tumors would be positive for GATA3, GCD, FP15, mammoglobin. And this is important for staging purposes to avoid unnecessary surgical procedures, mastectomy, lymphadenectomy, if it's metastatic from the ovary, not a primary breast carcinoma. And then the patient needs to be given appropriate chemotherapy. The prognosis is much worse if it's metastatic disease rather than if she had a separate primary in the breast. So in daily practice, the breast pathologists, when they see tumors, they pretty much think, well, most of them are primary cancers. But it's important to give accurate diagnosis. So what are some of the clues that, perhaps this breast tumor may not be primary? Well, it's very helpful if you know that the patient has another malignancy in a different part of the body and they tell us. And then other clues, if you're not told, would be, unusual morphology for primary breast cancer, for example, metastatic renal cell, with those foamy or clear cells. And then absence of a possible in situ component. Usually they're very well circumscribed nodules. And then, anytime there's any doubt, immunohistochemistry for site-specific markers would be helpful. So the objectives of these two breast core biopsy cases was to recognize papillary breast carcinomas and assess when they're invasive, because the prognosis and treatment is different. I've seen some cases that were just called breast carcinoma, no special type, or ductal, but try not to miss the papillary lesions because they are staged and treated more like DCIS. But if you do see high-grade features or obvious invasion, then only the invasive component needs to be measured for staging purposes. And as this last case showed, beware of metastatic mimics. It's helpful if you have a history. Many times we spend a lot of time doing chart reviews. Let's move on to our next case. A 51-year-old woman presents with a 7 cm breast mass, and by radiography, they are suspicious for malignancy. They did a biopsy. They didn't like what we called it, and so they did a subsequent lumpectomy. And this is what we received. So the core biopsy shows somewhat similar features, but this is part of the partial mastectomy or lumpectomy. So it's pretty cellular, and you can see cells of various types. In the background, there's a lot of fibrosis, and in between, you can see some sort of infiltrative cells here, other cells over here as well. High in magnification, showing that these darker cells are lots and lots of plasma cells. And then you have these cells with abundant cytoplasm scattered about as well. So, so what is your most likely diagnosis? Is this chronic granulomatous mastitis, IgG4 related disease? Could this be something sort of diabetic mastopathy? Could this be carcinoma or Rosai-Dorfman disease? Let's look at this here. Notice lots and lots of plasma cells and these paler cells that you see here with little blue dots there. So again, what stains would you do? Would you do gram stain, cytokeratin, S100, CD68, IgG4, lymphoma panel, all of the above, and or do you just not need any stains? So here's some additional history. We found out that the patient actually had a renal transplant. So of course we worried about certain infections or possibly lymphoproliferative disorders due to immunosuppression. Acid fast, GMS and PAS stains were negative. Cytokeratin stains were negative. We did flow and lymphoma panels, and all of those were negative as well. So actually, this is a case. The first core biopsy was called sort of lymphohistiocytic proliferation, sort of chronic mastitis. They sampled both the lymph node and the breast. So this actually is a case of Rosai-Dorfman disease, and the etiology is unknown. Perhaps some people react to certain antigens, maybe some viral insult, or in some cases, maybe a neoplastic process. It's usually very self-limiting with remission and relapse. It may be fatal if there's, systemic involvement. So Rosai-Dorfman disease, usually you have this lymphadenopathy, but you can also have extranodal disease, particularly in the skin, nasal cavity, CNS. And breast involvement may occur. It's uncommon. Oftentimes there's associated nodal disease, as in our case. So the thing that you really look for is the large activated histiocytes, and they'll be positive with S100, CD68 stains. Emperipoiesis, where you have intact lymphocytes and plasma cells or RBCs in the cytoplasm of these histiocytes. And there may be a fibrosis, but there's no obliterative phlebitis. Let's look at this again. Notice the fibrosis in the background, lots and lots of plasma cells, and these are the histiocytes. Again, they may be sort of perivascular or transmural sort of lymphoplasmacytic infiltrates, but then notice these paler cells in the background. These are the histiocytes, and notice emperipoiesis inside all of these. Stains, S100 is positive, and you can see these lymphocytes in the cytoplasm of these cells. CD68 is also positive. Again, notice the emperipoiesis. So Rosai-Dorfman disease in the breast can mimic carcinoma with nodal involvement. It's not very common, but you have to include this in the differential of histiocytic mammary lesions. And as much as possible, try and give a specific diagnosis rather than saying, oh, chronic inflammation, because then treatment may be appropriate, and it can prevent a radical surgical interventions or overtreatment. Rosai-Dorfman disease in the breast, the course is unpredictable. Sometimes it's self-limiting and patient can just be observed. Sometimes they may need to have steroids or surgical resection. In some cases, radiation, immune modulation, or antineoplastic therapy. Within 4 months, we had 2 cases of this. This older lady, she had very limited disease to the axillary lymph nodes and the breast, but a younger woman had lesions in one breast and the other breast, the thigh, as well as CNS as well. So again, please, try whenever you see chronic mastitis, just look to see, perhaps can you give something a little more specific? Some of the things that are in the differential diagnosis would be much more commonly diabetic mastopathy, patients with autoimmune diseases, and I've seen those being biopsied for a mass. And so try and give a specific diagnosis, maybe because of infections, ductictasia, lymphoma, as well as IgG4-related disease. Now, coming back to our case, are we missing something else? Notice this storiform fibrosis and these huge aggregates of plasma cells. So what else comes to mind? Should we do some other stains? Again, the storiform fibrosis and lots of plasma cells, as you can see here. So what's the other main differential, and do we need to do other tests? Well, you have to think about IgG4-related diseases. So this is IgG4, and this is the IgG stain. And for IgG4-related disease, you also want to see obliterative phlebitis, and lots of these IgG4 positive plasma cells per high power field, and you look at the ratio of IgG4 to IgG should be more than 40% or even higher. And also check the patient's serum IgG4 levels. And these patients can be treated with steroids and usually a nice clinical course. Now, so for IgG4-related disease, you want to see lots of IgG4 positive plasma cells, sclerosis, serum levels of IgG4 is elevated. Look for phlebitis, but you shouldn't see emperipoiesis and lack of these lesional histiocytes with emperipoiesis, as you see in Rosai-Dorfman disease. But our case has a little bit of both, right? So sometimes there's a spectrum, and they postulate that steroid therapy may be useful in patients with Rosai-Dorfman with some features of IgG4-related sclerosing disease. So, and it's recommended to evaluate IgG4 positive plasma cell infiltration in all cases of Rosai-Dorfman disease. This is just to some other things in the differential. If you see those foam cells and inflammatory cells, mammary ductictasia can give rise to that, but that's, you don't see emperipoiesis in that. Granulomatous mastitis can mimic breast carcinoma, and you would do stains and cultures for organisms. Here's a specific type of inflammatory breast reaction where you can have these granulomas and neutrophilic abscesses. You have these little empty spaces lined by neutrophils. And if you do a gram stain, you can see some gram-positive organisms. This is cystic neutrophilic granulomatous mastitis. It's been recognized somewhat recently. It's usually seen in women who are pregnant or lactating. I've also seen in patients with prolactinomas. So you have these lobulocentric granulomas with neutrophils, and it's somewhat similar to idiopathic granulomatous mastitis. And if you look at the empty spaces, you may see the faint rod-like Corynebacterium organism. Corynebacteria croppenstedti is the most common one, but there can be other types of Corynebacteria as well. And when you send this for cultures, we need to specify that we are suspecting corynebacteria infection, so we need special media like tween 80, and they need to be incubated for longer before saying, oh, nothing's growing on that. So the treatment is tetracycline, sometimes steroids, but in refractory cases, might need to do surgery. Sometimes a woman may have this granulomatous inflammation due to squamous metaplasia of the lactiferous duct, something more central, a strong association with smoking. The squamous metaplasia, and because of the keratin, there may be a granulomatous response to that. And it's important to specify that because sometimes these patients will not respond to just antibiotics. They may need to have incision and drainage for treatment. FNA of this would show these squamous cells. That would be a clue that, it's just because subareolar abscess or, squamous metaplasia of the lactiferous ducts. Diabetic mastopathy, sometimes when you look at the chart, you can see a patient is type 1 diabetes or has some autoimmune disease. And in these patients, you can see these lymphoplasmacytic infiltrates that may be around blood vessels or lobules or ducts with atrophy. And sometimes you can have this keloidal fibrosis and these epithelial myofibroblasts that can be quite concerning for carcinoma. What about breast carcinomas? Some breast carcinomas can have histiocytic morphologies, but then carcinoma would be nested rather than diffuse growth pattern. Look for the in situ component. Lobular carcinoma on LOPAC can resemble lymphocytes. And then if in doubt, always throw in some keratin stain so that you're not missing a carcinoma in the inflammatory background. So basically, try and avoid just giving a generic diagnosis of chronic mastitis. Try and identify specific entities because the treatment may be different. Although it's not common, think about Rosai-Dorfman disease in the breast. And in particular, you have to exclude IgG4-related disease. So next case, a 40-year-old African-American woman with a 3 cm upper inner quadrant breast mass, clinically suspected malignancy. FNA was performed and we gave a diagnosis. They weren't happy and they asked us to repeat the FNA. And this is what we saw. We saw these sheets of cells, very uniform, and the cytoplasm was eosinophilic and somewhat granular. So we said it looks like fibrocystic change. And here's an example, an FNA of a patient with fibrocystic change with those apocrine cells. And on the repeat aspirate, we saw the same thing, but they said, no, we really think this is malignant. So we said, okay, what are we missing here? So the cytoplasm is very granular, and notice there are lots of granules in the cytoplasm. So what other a lesion in the breast can have very granular cytoplasm. So one of the ones is a granular cell tumor, which is what the patient had. So we did the appropriate stain. So S100, PS diastase was positive. And when we said, hey, it's a granular cell tumor, they said, no, it has to be malignant. But remember, only 1 to 2% are malignant. The vast majority of granular cell tumors are benign. And the differential diagnosis would be fibrocystic change, apocrine carcinoma, melanoma, renal cell, or granulocytic lesions. Next case. 37-year-old woman with history of triple negative breast cancer. She'd had a mastectomy. Now she presents with fullness at the site of the mastectomy scar. And, the FNA or the biopsy shows something like this. So what do you think this might be? You can see some inflammatory cells, possibly, and there's some larger cells. And then what about this big cell and what's going on over here? So what do you think this is? Could this be just fat necrosis, implant reaction, recurrent tumor? Does the patient have sarcoidosis, or could this be just a seroma? So here's the giant cell with an asteroid body. Okay, so this was actually implant reaction. The best asteroid bodies you can see are in reactions due to implants. So before calling something sarcoidosis, look at the milieu and the clinical setting. So when patients have implants, you can have a reaction to the silicone in the implant. They don't necessarily have to leak for that. But what other conditions can arise due to implants? Some tumors in particular. So we all know about anaplastic large cell lymphoma that's more associated with those rough implants. Also, the FDA has released a statement in the past year about squamous cell carcinoma being seen with implants, usually posteriorly, and these are also associated with the smooth implants. You can also have other types of lymphomas, particularly EBV associated, and fibromatosis in implants. So I think I'm almost at my last case. We had these news headlines, a 9-year-old girl with breast cancer. So 9-year-old girl with cancer of the breast. Can you guess which type it might be? Here's what it looks like. You have these eosinophilic, sometimes clear cells, and you can see some central material in scattered in areas. This one will be triple negative, ER/PR, HER2 negative. This is an example of secretory carcinoma of the breast. It's usually very well circumscribed with pushing margins. It's not very aggressive. And you have these cells with vacuolated cytoplasm and PAs, diastase, positive secretions. It's triple negative. It's positive for cytokeratin, EMA, S100, and those secretions are PAs, diastase, positive. And it has this very classic fusion gene as seen here. So these have been described in the thyroid and particularly salivary glands. It used to be called mammary analog secretory carcinoma. Then they said, hey, it's much more common here. So we've taken away mammary analog. So everywhere it's just called secretory carcinoma, and this is the classic fusion gene. And interestingly, you see the same fusion gene in cellular mesoblastic nephromas and infantile fibrosarcomas. So just to end, please, 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 there's a lot of litigation for breast cases. So the pathologic diagnosis should be correlated with the clinical and imaging characteristics. So, if they're all concordant, you can be quite confident, but at tumor boards, etc., if they really think it's malignancy and you don't see it, was the lesion missed, or is somebody overcalling it, or is there something about this tumor that would make it appear clinically or by radiology as being malignant, or the main thing was a lesion missed, right? So that concludes my lecture. If there are any questions or comments, I would be very happy to answer them now.
Okay, so we are done with our first lecture. We will proceed to the second lecture on pancreatic cytopathology by Dr. Anwar Sultana Raza. So please, I will ask the secretariat to start the video for second lecture.
And my next lecture is going to be on pancreatic pathology. So pancreatic cancer is one of the leading causes of cancer death in the world. It's in one of the top 5 causes of cancer-related deaths, particularly in the West. The incidence appears to be increasing and is associated with very high mortality, and it's mostly because most patients present at an advanced stage. So there's a lot of emphasis on early detection by radiology as well as pathologic sampling, because with early diagnosis and some of the newer treatments, the patients can live longer, and in some cases can even be treated, because we can even see some pre-malignant conditions in some cases. Okay, so pancreatobiliary cytopathology, it's very minimally invasive. It's in good hands. It's pretty accurate. As you know, pathologists, we're being increasingly called on to diagnose disease in small and smaller specimens, particularly those that are procured under image guidance. So we don't really get pancreatic wedge and core needle biopsies as a first-line investigative procedure for pancreatic lesions. And now with these fine needle or these thin needle sort of uh, biopsies that we're seeing, there's less risk of complications such as pancreatitis, tumor seeding, and fistulas. And of course, it's also very cost effective. Some of the techniques would be intraoperative. Even if the patient has laparotomy, one of my former chiefs of AP said, don't just give me an FNA. I prefer looking at an FNA than a biopsy for this. But then oftentimes we get fine needle aspirations, either ultrasound guided through ERCP, and they use these thin gauge needles. Well, if you have thicker needles, then there's more chances of complications such as pancreatitis, hemorrhage, as well as tumor seeding. They say 5 to 7 passes are recommended. Good luck. And just know that the diagnostic yield depends on, multiple factors. Sometimes it's the tumor nature itself. So if you were to do an FNA of a normal pancreas, most of the tissue is pancreatic acinar and ductal. So you would see these pancreatic acinar cells with zymogen granules and maybe some honeycombed ductal cells. There's a much smaller endocrine component, and these would be the neuroendocrine cells, often bear nuclei or eccentric plasmacytoid nuclei with salt and pepper or coarsely granular chromatin. So the WHO classification, these are some of the main entities. Here's a simplified one. So we'll be talking about these lesions in today's lecture. So some of the clinical consideration is, is this a male or a female? Is it somebody old or young? So, your differential varies according to that. What are they thinking clinically? Are there any particular presentations that you need to know? And, what does radiology think? And again, the aspirator, what are some of the findings that may be pertinent? Does the patient have any prior history of tumor here or somewhere else? Any treatment? Is there a stent in place? And what exactly is the working diagnosis? So the interpretive algorithm is, is this lesion solid or cystic? Do you see non-contaminant abnormal tissue present? If not, then, if it's non-diagnostic, describe what you see. Just remember that cystic lesions are not going to be very cellular. You might ask them to get more sampling from the periphery. And always look to see, is there atypical thick mucus present in the background? And if you have cells, do you have atypia? And if so, what's the degree of atypia? So rapid on-site evaluation, you assist in slide preparation, staining. The pathologist or cytotechnologist assesses adequacy, and then they may request additional passes for cell block and, for triaging the specimen. And the main thing is it diagnostic? Do we have lesional tissue? And by having the pathologist or cytotechnologist there to assess adequacy, it decreases the procedure time. They're less inadequate or non-diagnostic specimens. And, and this has a lot of cost saving because of that. But just remember, assessment at the time of the needle aspiration should be as confident and as accurate as the sample permits. Don't be bullied into saying, oh yeah, it's, we have enough tissue. At low magnification, scan the slides to see, hey, do we have cells? How, are they necrotic? Are they well preserved? What's going on in the background? And if you have these cells, Do you see abnormal cells? Are they very crowded? Are they large? And, do you see nuclear membrane irregularities? What about the nucleus to cytoplasmic ratios? Is it dysplastic or frankly malignant? So pancreatic pathology, it can be easy or can be really, really challenging. And it is a huge, if you're giving somebody a diagnosis of pancreatic cancer, that's a big, big diagnosis. You have to be as confident as possible. So it can be agonizingly difficult in some cases, right? Here, the most common malignancy is pancreatic ductal adenocarcinoma, or PDAC. And, sometimes it can be very easy to diagnose. Look at this aspirate that's very pleomorphic. You have single cells, high nucleus to cytoplasmic ratio. There's so much pleomorphism. There's more than 4:1 size difference between the tumor cells. Again, over here, they sort of notice the mitotic figures, high nucleus to cytoplasmic ratio, clumped chromatin, marked pleomorphism between the cells, necrotic background. Here's another mitotic figure there. So abnormal cells, somewhat necrotic. And then when you look at the nuclear membranes of the PDAC cells, the nuclear membranes are very irregular. They're being likened to popcorn-like or tulip-like, where you have these linear grooves. So here's a sheet of pancreatic ductal adenocarcinoma. Notice the irregular chromatin, pleomorphism, irregular nuclear membranes. And here you can see some of those tulip or those nuclear grooves as well. Okay. Again, over here, notice the nuclear grooves, high NC ratio, pleomorphism, very three-dimensional, jumbled up, some really large cells, other cells not so large, and another nuclear groove here, or did I just point that out? Then it almost looks sort of honeycomb-like, but it's somewhat coming together in some places and loose there. So so-called drunken honeycombs, right? So that's been uh, something that you can see in pancreatic ductal carcinoma. So somewhat tipsy little sheets of cells. So PDAC is, majority of pancreatic carcinomas. If it's in the pancreatic head, patients may present early with obstructive jaundice. But if it's, in the body and the tail, the presentation may be late, often with meds. It's a very common cause of carcinoma from unknown primary to lymph nodes and elsewhere. Sometimes the patient may have a migratory thrombophlebitis, which is Trousseau's a sign where a patient has pain in different parts of the body, and that's because of the pancreatic ductal carcinoma and some of the enzymes that are being released. So PDAC, you see disorderly, drunken honeycombs, high NC ratio, large cells, they may be squamoid, sudden large tombstone-like tall columnar cells, nucleomegaly, much larger than red blood cells, anisonucleosis, 4:1 or greater difference in size between different nuclei, irregular nuclear membranes with those popcorn tulip shapes, and abnormal chromatin, thick irregular nuclear membranes. You can see prominent nucleoli and start seeing mitosis, maybe necrosis in the background. So here's pancreatic ductal carcinoma. Notice the infiltrating nature, irregular nuclear membranes that you can see here, high nucleus to cytoplasmic ratio, and pleomorphism, as you can see over here, very irregular nuclear contours, prominent nucleoli, and pleomorphic malignant nuclei. And you can do stains for pancreatic ductal adenocarcinoma. So sometimes it's easy, but sometimes it could be a little challenging. Sometimes it may be a little more subtle. Are these super reactive cells, or could this be malignancy. Again, compare with RBCs, these are very large. There's irregular thickening of the nuclear membrane, and you may see some nuclear membrane irregularities. Three-dimensional, there's overlapping nuclei, maybe necrosis in the background as well. This foamy gland type of pancreatic ductal carcinoma can be very deceptive, and this can be missed. I remember there was a frozen section on one of the cases, and it was thought to be just something benign, but actually this is the foamy gland type, and this one you have these basally situated nuclei. Something quite characteristic is at the apex of these tumor cells, you have these sort of thickening, sort of like a brush border appearance, as you can see over here. So so that's pancreatic ductal carcinoma, but nowadays with imaging techniques, patients being worked up for something else, we're picking up earlier or precursor lesions, and these are pancreatic intraepithelial neoplasia. They may be seen in the resection specimens around where you have PDAC, or intraductal papillomucinous neoplasms, as well as mucinous cystic neoplasms. So here is an example of pancreatic intraductal neoplasia panning. So it's called low grade or high grade. This is obviously high grade here, as you can see, and this is a precursor to invasive pancreatic ductal carcinoma. Here's one case. The clinician said when they were trying to biopsy the pancreas, they went through the duct, and there was ampullary mucorrhea. A lot of mucus came out. And notice here there's a dilated duct with tumor inside. And here's one of these opened up. So here's the duct opened up, and notice this papillary tumor inside that. So intraductal papillomucinous neoplasm, it's more common in the head of the pancreas. So radiology as well as clinical findings are very essential. It can be single or multilocular cysts, and these may be either in the main duct or the branch ducts, or maybe mixed both in the main as well as the branch ducts. So there's abundant mucin, often flowing from the patulous ampulla at the time of endoscopy. And then you have these papillary islands and fragments that are greater than 5 millimeters. And when you see these mucinous cells, we have to say, well, is it low grade or high grade? And these have potential for malignant transformation, and it's better prognosis than usual pancreatic carcinoma because it's still intraductal. And here's an example of IPMN. Notice these proliferation. It's still limited by the basement membrane, and there's pleomorphism here. Oftentimes in aspirate, you'll see these sheets of cells, and you can see it's almost like a layer, as you can see over here. And these IPMNs, they may be lined by intestinal type epithelium, or it may be gastric foveolar type of epithelium, or pancreatic type of epithelium, pancreatic ductal. These tend to be more amphiphilic or cuboidal. The intestinal type may be associated with mucinous, obvious mucinous tumors, and actually with mucinous or colloid carcinomas. You can also see oncocytic type of intraductal proliferation. So here you can see the oncocytic intraepithelial ductal proliferation, as you can see here with prominent nucleoli. And something to be aware of, we went back in our files, and there were some IPMNs and sort of mucinous cystic neoplasms that the first FNA, we thought non-diagnostic. We said, hey, we don't really see anything. What we missed was there was blood in the background, but there was mucin. Notice the mucin here. Sometimes it can be sort of cracked, as you can see, almost like cracking, as you see in colloid. And they say now that if you see all this thick extracellular mucin in the correct clinical context, it's enough to call it either an IPMN or a mucinous cystic neoplasm. You don't necessarily have to see the cells for that. And you can, the various stains that can be done for IPMNs. So that was the introductal papimucinous neoplasm. And then you can also have these other cystic mucinous neoplasms that are not associated with the duct. So you need radiology for that. They can be unilocular or multiloculated, as is seen over here. And these can be lined by these mucin-producing cells. You've got these mucin-producing cells, as seen here. And here's an example of a mucinous cystic neoplasm with low-grade dysplasia. But notice just beneath that, you have this ovarian-like stroma. And if you stain this, that would be positive for ER, PR, inhibin, and calretinin. Okay. Here is a mucinous cystic neoplasm with high-grade dysplasia. The ovarian-like stroma may not be very obvious, but if you do the stain with inhibin, it may be highlighted. But again, you need radiology because the mucinous cystic neoplasm are not associated with the ductal system. So here's a mucinous cystic neoplasm, and I can do stains with ER, PR, for the ovarian type of stroma. Again, a mucinous cystic neoplasm. Notice the mucin there, and then these are the tumor cells. When you see that, you have to say whether you see low-grade or high-grade dysplasia. So these are very indolent tumors, and you have to sample these very well. Just like all mucinous tumors, you may have very bland areas and, marked high-grade dysplasia right next door. So sample these very well. Important, these ones are not in continuity with the pancreatic ductal system, and you have both intracellular and extracellular mucin, and the subepithelial stroma resembles ovarian stroma, and the stromal component is positive for inhibin, ER, and PR stains. So when you have these mucinous neoplasms, then we say mucinous neoplasm not otherwise specified unless you know by radiology that was inside, a main duct or a branch, or it was not associated with a duct. But we have to grade the dysplasia if it's low or high grade dysplasia. And, again, as I mentioned, we need the radiology. So you can get a lot of cystic lesions in the pancreas. 2% of these pancreatic neoplasm may be cystic. You may have the serous cystadenoma or microcystic adenoma. And then we just talked about the mucinous tumors. This is, again, a recap of the mucinous cystic neoplasm not associated with ducts, IPMNs that may be associated with the main duct, branch ducts, or mixed with both. And then a serous cystic neoplasm. This has very characteristic radiology, so oftentimes they're pretty confident as to what that is. And then the pancreatic pseudocyst, usually there's a history of pancreatitis, and this tends to be near the tail of the pancreas. So you can get various non-neoplastic cysts, and pancreatic pseudocyst is quite common. And the aspirate can be very therapeutic, and you can see inflammatory cells, some bile pigment, and sort of granulation tissue-like material, so no true lining. Notice there's some pigmentation here, foam cells, inflammatory cells. So, clinically it fits with pseudocyst. And also when they aspirate these cystic lesions, the GI physicians, they send the cyst contents for amylase and lipase contents, and the CEA would be low in the pseudocyst, the amylase and lipase would be high. Okay, so here's a somewhat easy case. I was on a weekend call some years ago, and I was called in to do a frozen section and on a 7-year-old female with a pancreatic mass. So a 7-year-old girl with a pancreatic mass. So what are you already thinking about? Okay, so here's the aspirate. It's pretty cellular. You can see all these cells here. And then it almost looks like there's a capillary with these elongated nuclei in the center, and the chromatin is sort of salt and pepper, sort of coarsely granular. You can see here sometimes there's some single nuclei. There may be some cells with nuclear grooves. Okay, another view showing these sort of capillary network and these tumor cells around these vessels. Again, lots of these dishesion and single bare nuclei in the background. And in some areas, you can see these PAS diastase positive globules here. This is the cell block appearance. Again, pretty cellular, and you can see the tumor cells here. So this is an example of a solid pseudopapillary neoplasm. It's seen in young women, usually in the tail of the pancreas. It's malignant, but it's a low-grade malignancy. So it has indolent growth. And it, by radiology, young woman, cystic and solid mass, the first thing you think of it, could this be a solid pseudopapillary neoplasm? And your differential would be other aspirates or tumors with similar nuclear features. So these FNA would be highly cellular. You can see those bare capillaries with tumor cells around them. Monomorphic tumor cells, bland nuclei, sometimes nuclear grooves. Sometimes you can see these globules. They can be intracellular or extracellular. And it's positive for synaptophysin, but negative for chromogranin, INSM1 as well. This is the histology showing the vessel in the center and these tumor cells around that. And in some areas, you can see those globules as well. So some of the stains, beta-catenin would be both positive in the nucleus and cytoplasm. CD10 is positive, PR positive. It's it's NSC positive, but synaptophysin chromogranin negative. It looks neuroendocrine, and there's loss of E-cadherin, and your differential would be neuroendocrine lesions. Okay. So now, next case, I've seen some people at seminars and on tests ask you about this. If you have a pediatric patient with a pancreatic mass and you see lots and lots of tumor cells, but notice over here, you've got these little nests or whorls or these squamoid nests. So these are very characteristic in pediatric patients for pancreatoblastoma. So it's the most common pancreatic tumor of infancy and early childhood. You have acinar differentiation. Those squamoid corpuscles are very, very characteristic. And sometimes you can have heterologous structures. There may be bone or cartilage associated with them. Cytology resembles acinar cell carcinoma, but it's the morioles that are very, very specific. And then beta-catenin would be giving nuclear staining, synaptophysin and trypsin would be positive as well. Okay. So we talked about pancreatic ductal, mucinous tumors, solid papillary tumors, pancreatoblastoma. Another common pancreatic neoplasm would be this particular tumor. Notice you have these scattered cells, maybe bare nuclei, somewhat plasmacytoid appearance, maybe a hint of rosetting that you can see here. Salt and pepper chromatin pattern, bare nuclei. So this is an example of pancreatic neuroendocrine tumor, or the PNETs. Okay, and these can be single cells. You have these plasmacytoid cells with granules in the cytoplasm, and a coarsely granular chromatin, and then so low-grade PNETs, or you can have primary small cell carcinoma as well. So these neuroendocrine neoplasms are seen in older adults, and these are associated with long survival, even with metastatic disease. However, there may be life-threatening manifestations due to excess hormone production. Since the islets are more common in the body and tail of the pancreas, we tend to find these neuroendocrine tumors more commonly in the body and tail of the pancreas. And for the most part, they're slow-growing tumors. Steve Jobs, the Apple co-founder, he was diagnosed with a pancreatic tumor, and he thought, oh, it's going to be pancreatic ductal carcinoma. I know the prognosis, don't do anything. But then he was doing well. So finally, he was convinced to have it biopsied. And it turned out to be a pancreatic neuroendocrine tumor. But being Steve Jobs, he decided to go for alternative therapies. But still, you know, he lived longer than you would with asthma or pancreatic ductal carcinoma. So here's an example of well-differentiated pancreatic neuroendocrine tumor. And notice very uniform cells, but in neuroendocrine tumors, you can have this endocrine atypia. The chromatin is coarsely granular, salt and pepper chromatin. The insulin-producing tumors can have sort of amyloid, maybe associated with amyloid production, as is seen here. There are various clinical syndromes that can be seen with pancreatic neuroendocrine tumors, maybe associated with MEN1. The insulin-producing neuroendocrine tumors are benign for the most part, but the patient may have severe hypoglycemia, and that can be life-threatening. The gastrin-producing tumors are benign if associated with MEN1, otherwise they can be malignant. Glucagon-producing tumors are often malignant, and the patients may present with skin rashes, and these tumors tend to be large. Somatostatin-producing tumors, you may see Samoma bodies. So if you see a neuroendocrine tumor with Samoma bodies, then you have a pretty good idea that that's going to be a somatostatin-producing tumor. And then ACTH parathormone-producing tumors are more likely to be malignant. You can also get a clear cell variant of neuroendocrine tumors where you have sort of frothy or bubbly cytoplasm, as is seen here. And this can be stained with neuroendocrine markers as positive for chromogranin, but then inhibin is also positive. And this can also be seen in patients with von Hippel-Lindau syndrome. So here's a patient with migratory sort of erythema. And so which tumor cell type? So, you know, the malignant glucagon-producing tumors can have these skin manifestations. So some of the new classifications for the neuroendocrine tumors. Before we just had a grade 1, a grade 2, and then sort of grade 3 neuroendocrine carcinoma. But now for the well-differentiated neuroendocrine tumors, they've added a grade 3. So grade 1, less than 2 mitoses per square millimeters, 2 square millimeters. Ki67 is less than 3%, and a grade 2, so-called atypical sort of carcinoid in the olden days, we have 2 to 20 mitoses per 2 square millimeters, and the Ki67 is 3 to 20%. But now they've added a grade 3 where you have increased more than 20 mitoses or Ki67 more than 20%, but it still looks well differentiated. And it's important that the Ki67 count should be done on a minimum of 500 cells in hotspot areas. Both the mitotic count and Ki67 should be performed. And, you know, the higher the grade is assigned on the largest value, it's usually the Ki67. And they don't just eyeball things, they propose printing out a hotspot area of the tumor and then doing a manual count on those. Per WHO 2019, neuroendocrine neoplasms with Ki67 more than 20% now are in two distinct groups: the well-differentiated neuroendocrine tumor grade 3 or polydifferentiated neuroendocrine carcinoma, and that's based on the morphology. So for the neuroendocrine carcinomas, there's small and large cell types. The Ki67 rate is very high, often, more than 60%. And of course, the mitoses are very high as well. And this is an example of, a very rare small cell neuroendocrine carcinoma, primarily in the pancreas. Okay. Now, the next case is another pancreatic primary tumor. Notice here you have these tumor cells. Again, lots of bare nuclei in the background. So sort of resembles neuroendocrine tumors or even solid papillary neoplasm. Notice these groups of cells, lots of bare nuclei, and maybe traversing capillaries in between. And if you look at some of these cells, notice there's granularity to the cytoplasm. Here's some bare nuclei. This is an example of acinar cell carcinoma. These are the zymogen granules in the cytoplasm. So acinar carcinoma, 1% of pancreatic carcinomas. The prognosis is as bad as pancreatic ductal adenocarcinoma, NOS. And these tumors, because of those zymogen granules, they may secrete amylase, lipase, or elastase. And patients may present with skin manifestations, florid fat necrosis, polyarthralgia. And oftentimes these are poorly differentiated. So how do you recognize these? They look like acinar cells, but you have these single cells, lots of bare nuclei in the background, granularity of the cytoplasm, prominent nucleoli. And if you do the stains, BCL10 and trypsin would be positive. Sometimes you can have these sort of giant cell carcinomas in the pancreas, or really ugly polydifferentiated carcinomas. Some of the pancreatic carcinomas may have these squamoid features as well. And so, of course, you want to make sure it's not metastatic from somewhere else, but just remember that pancreatobiliary neoplasm can have some squamoid features. Here's a pancreatic lesion, and radiology is very distinctive. This particular tumor is very, in this case, is multiloculated. Oftentimes they'll say there's sort of a central stellate scar, maybe sunburst calcifications in this. And this is a classic for a serous adenoma. It hasn't usually benign and associated with an excellent prognosis. Oftentimes these patients are followed up, and if they become symptomatic, then they may be excised. There's an increased incidence in patients with von Hippel-Lindau disease. It may be multicystic, often that honeycomb pattern. And then you have these very, very bland appearing cells with glycogen in the cytoplasm. So they're PAS positive lining cells, and very, very vascular. So on aspirates, there's a lot of blood. Again, showing the clearing of these cells. And if you were to do a stain for glycogen, PAS, it would be positive. Diastase would be, washed out. On FNA, very bland appearing cells, and you can do inhibin stains would be positive, as well as PAS stains. Oftentimes with the radiology and these sparse cells, lots of blood, you can confidently make a diagnosis of this. Okay, now the next case, one of our trainees went away to do a fellowship and came back and was signing out one of the pancreatic resection cases. So there's this middle-aged male presented with his pancreatic mass, and so a Whipple section was performed. And then she was quite perturbed because this is all she saw. And, she said, hey, where's the cancer? Do I need to go back and put more sections in? She'd sampled it quite well. She'd put additional sections in again, but, she didn't know, what am I going to tell the clinician? So what are we seeing here? Notice that you have some ducts here, a loss of normal pancreatic histology, but then you see a lot of these small small cells, blue cells. So these are lymphocytes and lots of plasma cells. Here's a higher magnification showing lots of plasma cells and interspersed lymphocytes, maybe some fibrosis going on. Okay, and here's a blood vessel, and you have obliterative phlebitis. So the vein is being destroyed by this. So plasma cells, fibrosis, obliterative of phlebitis. You think about IgG4 disease, right? So IgG4 stains were performed, and this is an example of autoimmune pancreatitis type 1, which is IgG4 related. It's seen in older patients, often with presents with jaundice and a mass. The pancreas appears enlarged, and the classic features are hypercellular lymphoplasmacytic infiltrate, storiform type fibrosis, and obliterative phlebitis. If you do the serum levels, IgG4 levels should be increased, and on biopsy, you want to see more IgG. The IgG4 to IgG ratio is greater than 40%, and and also on biopsy, more than 10 IgG4 plasma cells per high power field. So we're getting requests by clinicians when they do the aspirates, can you check for IgG4? So we do the stains, but in resections, you want to see greater than 50 IgG4 positive plasma cells per high power field. And these infiltrate may not just be in the pancreas, it can also extend to the peripancreatic tissue. Oftentimes, there's a history of sclerosing cholangitis or other type of autoimmune diseases. Sometimes it's not just the obliterative phlebitis, you may also see arterial involvement. So IgG4 related disease, classic sclerosing cholangitis, autoimmune pancreatitis, retroperitoneal fibrosis. We might get biopsies, lacrimal biopsies are looking for IgG4 related disease. You can also have IgG4 related disease in the salivary glands and other body sites as well. Another type of autoimmune pancreatitis is type 2, and this one is very duct-centric and usually younger patients with a history of inflammatory bowel disease. And this you look for periductal inflammation and neutrophilic microabscesses. And I've seen some FNAs and small cell blocks biopsies. And when I see I don't see any tumor, but I see the these ducts and acute inflammatory cells, I might say, hey, could this be that? And you ask them to correlate clinically. So here, notice these small ducts and the associated neutrophils with this as well. Okay. Pancreatic tumors, sometimes you can have tumors, invasive tumors, but notice lots and lots of mucin in the background. So this is an example of colloid carcinoma. This sometimes a precursor lesion may be the intestinal type of lining of IPMNs. The intestinal type epithelium may be associated with these mucin-producing colloid carcinomas. And these ones are microsatellite stable, so they're not associated with Lynch syndrome. And these one also have that inverse polarization of the tumor cells. So if you do the EMA stains, you would see reverse polarity of that. Another type of pancreatic carcinoma would be a medullary carcinoma, where you have these sheets of tumor cells and there's associated lymphocytes and plasma cells with that. And these are very rare. These are associated with Lynch syndrome, in 50% of cases. So the patient may have a history of colonic carcinoma, cancer at other sites, maybe endometrial carcinomas, ovarian carcinomas, maybe clear cell type. These ones have a somewhat better prognosis. You look for sheets of tumor cells, there's necrosis, large vesicular nuclei, prominent nucleoli, and often intraepithelial infiltrate of lymphocytes. They may be associated pancreatic intraepithelial neoplasia. And if you do the stains, there's loss of the MSI markers. Okay. Now, what about some other lesions that may be a little more rare? Okay. So I had a young child present with a pancreatic head mass and common bile duct compression. So FNA was performed, and this is what I saw. So basically, some inflammatory cells, it's really uh, sort of some blood vessels possibly here. And then on the cell block, this is what I saw. I saw maybe some fibrosis, inflammatory cells as seen here, some residual ductal or acinar structures, but again, there's some fibrosis and inflammation. So, I said, well, what could this be? A young child? So this is an example of idiopathic fibrosing pancreatitis. So you can see inflammatory cells and the associated fibrosis. And it's rare, often seen in young patients. Our patient was 9 years old. Patients often present with obstructive jaundice and abdominal pain. And because of this fibrosis and chronic inflammation, there's atrophy of the exocrine pancreatic parenchyma, but the islets are preserved. So the treatment is to just stent the patient and give, sort of bypass surgery if the stent doesn't work. Our case, a patient was stented, and the differential diagnosis is autoimmune pancreatitis. So you would want to check for IgG4 levels, etc., in the patients. So I was very happy. Like the first FNA, I called the GI doctor and I said, I really think, this is what it is. It's that idiopathic fibrosing pancreatitis. But because of this sort of mass in the head of the pancreas, he didn't quite believe me, and he FNA'd the patient. And again, we just saw, similar findings. And so I said, no, it still fits with that. Please correlate with clinically. And so we did a poster presentation at the CAP about this, and it was presented. But then just now when I was, and I included my clinicians, radiologists in that case, but now when I was presenting this conference, I realized, unbeknownst to me, he and his team went ahead and published this with using my images without any acknowledgement of the fact that, I had diagnosed it. And so that happens to us pathologists. We do all the hard work, but somebody else takes the credit for the diagnosis. But the good news is for the patient that they're going to be, it's not, malignant neoplasm, and they perhaps, just with stenting and follow-up, a patient will do okay. So in pancreatic pathology, you have to be very aware of cross-contamination and know where in the pancreas the lesion was. So if it's the head of the pancreas, then they will probably go through the duodenum, so they can pick up, just duodenal epithelium. These it gives you this appearance with those goblet cells in the center. Sometimes Brenner's glands can be picked up, and those can be overdiagnosed. And then if it's in the body, in the tail, then they will be going through the stomach. So it can have a gastric epithelial contaminants as well. We've seen times when, you can have liver being inadvertently sampled. So always think, hey, could it be something else? We had a patient with a lesion near the tail of the pancreas, and they did an FNA, and we had these small single cells, and we said, well, it could be a neuroendocrine tumor, until one of our colleagues said, it looks very lymphoid. Could it just be a splenic tissue? So they could, sort of inadvertently sample the spleen, or there may be an accessory spleniculus very close to the pancreatic tail. So that's something else to consider as well. And then, other kinds of contaminations as well. You may have metastases to the pancreas, and oftentimes it's known disease. And when you know that the patient has some other tumor and now presents with a pancreatic mass, your main thing is this a second primary, or is this metastatic disease? And these are some of the things that you could see. And here, for example, very classic for colon carcinoma with those cigar-shaped nuclei, dirty necrosis. You would consider metastases if the tumor cell morphology isn't typical of the usual primary pancreatic tumors, particularly when you see very small cells, squamous cells, but again, pancreatobiliary tumors can do that. Small cell carcinoma, I showed you that picture of somebody with the head down, because it's super rare to have small cell neuroendocrine carcinoma of the pancreas. It's very lethal. And one of my dear colleagues was diagnosed with that. And, she fought the good fight and died very young due to that. And then also consider METs when you have, obviously if you have a history of primary somewhere else, and, do an ancillary study. It's so important nowadays to preserve tissue. You want to make as accurate a diagnosis as possible, and not just preserve tissue for doing immunohistochemical stains, but really also for molecular. It's super important to have adequate tissue left over for molecular testing. So basically, the two major indications for pancreatic fine needle aspirations is to evaluate pancreatic masses, documentation of malignancy prior to therapy, and then accurate staging of patients with pancreatic carcinoma. And by doing this, you avoid the expense, morbidity, and mortality related to unnecessary surgery. What if the patient is inoperable, but at least you get a diagnosis, they can go on to neoadjuvant therapy and be put on certain clinical trials. The impact on cost and management of pancreatic cancers has been evaluated, and it's, there's substantial savings if you can diagnose without exploratory laparotomies. First give a diagnosis, then see if the patient is a good candidate for resection. First get a diagnosis, what kind of tumor it is, stage the patient, and then see if the patient is a candidate for surgical exploration. So I just met one of the pioneers in pancreatic cytopathology, and he started working with his GI colleagues on cytology of pancreatic lesions many years ago, so much so that he just mentioned that there was one patient who really wanted to know what that pancreatic mass was, and that patient paid this pathologist to travel from the US to Canada to assist in the evaluation at the time of fine needle aspiration, and triaging of the specimen. So a lot of cost savings and a diagnosis for the patient because of that. So that's very, very beneficial. So now we have a staging system for pancreatobiliary cytology reporting. And in these, you have these various categories: non-diagnostic, or if you have a lesional tissue, it's benign. It could be a neoplastic benign or non-neoplastic. And, good example of benign neoplastic would be a serous adenoma. And the clinicians would also send part of the aspirate for CEA and amylase levels. In some places, they're also sending it off for other markers. Again, if there's the CA and amylase levels would be very beneficial. The carcinomas, adenocarcinomas, would be high in CA, carcinoembryonic antigen levels. And then if you have pancreatic neoplasia, these are stratified into low risk or low grade, so-called pan-low, or high grade, high risk dysplasia. So the IPMNs, they're risk stratified into pan-low or pan-high, and that's very beneficial. And then if you're suspicious for malignancy, and the reason is it's either quantitatively or qualitatively just short of you giving a definitive diagnosis for malignancy. And in those cases, these patients should be presented at tumor boards, like a sort of multidisciplinary team. And if, clinically, radiologically, by additional testing, it's pretty obvious that it is most likely malignant, or you can see regional lymphadenopathy. Even if you say suspicious for malignancy, it can be treated as positive. But of course, the clinical and imaging findings need to be concomitant, or sometimes you can just be very definitive and say it's obviously malignant. Okay, this one's a little small, and I just wanted to just go into more of these diagnostic categories that we have, sort of insufficient, benign, negative. It could be neoplastic or non-neoplastic, atypical, pan-low, again, pan-high, suspicious, and positive for malignancy. And then this, gives examples of some of the lesions. So some of the benign ones, acute pancreatitis, chronic pancreatitis, autoimmune pancreatitis, ectopic splenic tissue, lymphoepithelial cysts. Unlike in the salivary glands, these are not associated with HIV. They can have pseudocysts, and then, of course, the benign serous adenomas. For atypia, you do the CA and amylase levels. These are the estimated risks of malignancy, and follow up by doing a repeat FNA. If it's malignant, then sometimes you get better sampling on repeated aspirations. And then a pancreatic neoplasm, low risk and high risk. It's the degree of dysplasia in these pannin or mucinous cystic lesions. And you can do surgical resection if the patient's fit, or sometimes sort of conservative management. Suspicious for malignancy, you have atypical epithelial cells. So the estimated risk of malignancy is high. So if you correlate that clinically and radiologically, then you can go for definitive treatment. And then positive for malignancy, we can diagnose acinar, ductal carcinomas, which is the most common, cholangiocarcinoma, lots of sclerosis. Again, radiology is important. You can do immunostains, neuroendocrine tumors. Is it a low grade, grade 1, 2, 3 neuroendocrine tumors, or it's just neuroendocrine carcinoma, which cell type, pancreatoblastoma in young, infants. solid pseudopapillary neoplasm more in women, younger patients, although we had an 82-year-old with that. So, it doesn't have to be just very young patients. And then, of course, metastatic malignancy. This is my institution, Loma Linda University. It's on the outskirts of, it's east of Los Angeles, and this is San Bernardino County, and these are the San Bernardino Mountains with Lake Arrowhead that, in olden times, all the Hollywood celebrities would be vacationing up there. So once again, I want to thank you all for joining us in this symposium and this lecture. And thank you to Dr. Omar Sheikh again. And if there are any questions or comments, please let's discuss now. Thank you.
Thank you so much, Dr. Raza, for these lectures. And now we will take a break for 1 hour and we will resume with the third lecture at 3 p.m. inshallah. Okay.
इसको मैं क्लिक करूंगी तो स्टार्ट हो जाएगी इसको क्लिक करूंगी तो स्टार्ट हो जाएगी मेरी Assalamu alaikum. I'm Dr. Mariam. I hope you have enjoyed the previous 2 sessions of the symposium workshop. I think they were very excellent sessions on cytopathology, especially for trainees, because it built the basic foundation of cytopathology in the breast and pancreas. And you can always build on top of the basic foundation and add according to your experiences. So I hope you have learned a lot. At this time, I would ask every one of you to please write down your questions in Q&A box, and they will be answered at the end of the session around 5 o'clock. So keep on posting on the question answering session for the question and answer session. And we will consider all the questions at the end of the session at 5 o'clock. So our next talk is about the molecular pathology, and its significance cannot be emphasized enough, especially with the advent of the new pathological techniques and AI coming in and digital pathology coming in. So obviously, molecular pathology is getting significant attention here. But in our part of the world, I think the most important thing for the pathologists and the pathology residents at this time is to know the basics of molecular pathology and what its significance is. Dr. Junaid Ibrahim is going to present it, and he has expertise in the areas of surgical pathology, molecular pathology, and cytopathology. He has authored many peer-reviewed articles. Dr. Ibrahim is an associate professor of pathology and medical director of head and neck and endocrine pathology service at Baylor College of Medicine, USA. We are honored to have Dr. Junaid with us live also, but his talk will be recorded. And so we'll have the recorded talk first, and we'll have him for our Q&A session at the end of the talk. Thank you. We'll start the recording now.
Assalamu alaikum, everyone. My name is Junaid Ibrahim. I'm currently working as an associate professor of pathology and immunology at Baylor College of Medicine in Houston, Texas. I'm grateful for the opportunity to be able to speak with you today. I have nothing to disclose. I have divided my talk into 5 segments. I will first go over the basic structure and function of DNA. After that, I will go over some of the basic concepts in molecular pathology. Then, as a practicing surgical pathologist, one of the major responsibilities that we have is to be aware of the tissue requirements and tissue considerations for solid tumor next generation sequencing. So I will go over those tissue requirements with you. I will go over the next generation sequencing. My focus would be to go over the spectrum of clinical NGS testing and solid tumors. I will briefly go over the chemistry of next generation sequencing as well. And finally, I will go over some of the important components in molecular pathology report. Let's start with the basic structure and function of DNA. This is the basic structure of DNA. As we know, DNA is a double helix, which means that it is made up of two strands, and these strands are complementary to each other, and these strands are anti-parallel to each other. If you focus within the arrows, you can see that the DNA is made up of repeating units of sugars, and these sugars are joined together by phosphodiester linkages between 3' carbon of one sugar and the 5' carbon of the next sugar. So these sugars also have attached bases. So the bases attached to one strand will form hydrogen bonds with the bases attached to the opposite complementary strand. What I would like you to appreciate in this picture is that the DNA strands, they have a polarity. There is a 5' end and then there is a 3' end. So 5' end is basically the end that has a terminal 5' carbon. And 3' end is the end that has an unlinked hydroxyl group. So this is important to realize because DNA is synthesized in a 5 to 3 direction and DNA is read in the 5 to 3 direction. This is the central dogma of molecular biology. This shows you the flow of genetic information from DNA to RNA to protein. So DNA is first transcribed to RNA and RNA is translated to protein. There can be exceptions where RNA is reverse transcribed to DNA, but there is no flow of information from protein to protein or from protein back to nucleic acids. I would like to imagine your DNA has a very, very long stretch of nucleotides. And within this very, very long stretch of nucleotides, there are small regions which code for proteins. And these are the regions which we call genes. So genes only account for less than 5% of our DNA. So you would ask, what does the other 95% non-coding DNA does? So one of the functions that this non-coding DNA has is that it has regulatory sequences, as you can see in yellow in this picture. So these regulatory sequences, although they do not code for the gene, for the protein itself, they control the gene expression. So this picture basically shows you the structure of a gene as shown in the red. So the gene will be first transcribed into a precursor messenger RNA molecule. And then this precursor messenger RNA molecule undergoes post-transcription modification, and we get the final product in the form of mature messenger RNA. So as you can see, genes are also made up of exons and introns, and introns are the non-coding regions within the gene. So as a result of post-transcription modification, these introns are also spliced out so that the end product that we get in the form of mature messenger RNA, it has a single continuous protein coding region. So talking about the regulatory sequences, promoter regions are the regions where the RNA polymerase or the transcription factors will bind and initiate transcription. So effectively, promoter regions, they can control gene expression. They can turn on or turn off the genes. This is the final product. As you can see that we have a single continuous protein coding sequence as shown in the green. Upstream and downstream of this protein coding sequence, we have a 5' untranslated region and a 3' untranslated region. So 3' untranslated region has the termination sequence, which results in the termination of the transcription process, and that allows RNA polymerase to be released. 5' untranslated region is the site where the ribosome will bind. So in addition to intron splicing during post-transcription modification, a 5' cap and a poly A tail also get added to the messenger RNA. So essentially, the function of these two is to provide stability to messenger RNA so that it does not get degraded. Also, these will facilitate transport of messenger RNA into the cytoplasm to the ribosome. So once the messenger RNA is in the cytoplasm, it will find its way to the ribosome. And here, the genetic information in messenger RNA will be read and translated into protein. The way it takes place is that we have transfer RNA molecules that carry specific amino acids, and they have anticodon at one end. So a transfer RNA molecule that has an anticodon complementary to the next codon on the messenger RNA will be able to bind and add amino acid to the growing protein chain. So the genetic information in the messenger RNA is read in the form of codons. So these codons are a set of 3 consecutive nucleotides. And transfer RNA molecules, they have anticodons. So anticodons will be complementary to the codons on messenger RNA. This is the codon table or the codon wheel. And this shows you that we have 4 different types of nucleic acids, the A, G, U, and C. So as we just discussed that codons are a set of 3 nucleotides. So if we were to generate codons using these 4 different nucleotides, we can possibly generate 64 codons because 4 times 4 times 4 is 64. So we have 64 codons, but we only have 20 amino acids. So that means we have way more codons than we have amino acids. So more than one codon can code for the same amino acid. And I also wanted you to appreciate that as you can see in the center of the picture, there is a 5' letter. So that means that if you were to read this codon table, you have to read from the center of the table because DNA or RNA, it is read in the 5 to 3 direction. So if you were to read stop codons, you will start with the U in the center. So UAA, UAG, and UGA. These are the 3 stop codons, which will not code for any amino acid. They will end the process of transcription. So out of 64 codons, we have 61 codons that code for amino acids, but 3 codons are actually stop codons, which end the process of protein synthesis. So genetic change is when there is a change in the sequence of DNA. Epigenetic change, on the other hand, is a change when there is nothing wrong with the sequence of the DNA. There is no mutation. Sequence of DNA is completely normal, but there are some epigenetic factors that can bind to the DNA, or they can bind to the histones and alter the gene expression. So there are 2 mechanisms, DNA methylation and histone modification. So DNA methylation is when methyl groups bind to certain regions in the DNA. For example, methyl groups can bind to the cytosine residues in the promoter regions of the gene. So when they bind to the cytosine residues in these promoter regions, and that results in hypermethylation of the promoter regions, and the result is the transcription factors, they cannot bind to the promoter region anymore. And we discussed that is needed to initiate transcription. So essentially, there is nothing wrong with the gene sequence, but since the promoter region is methylated and transcription factors cannot bind to the promoter region, we cannot have transcription. So essentially, gene has been silenced or turned off. So DNA methylation can turn on or turn off the gene expression. Similarly, histones are the proteins around which the DNA is wrapped around. So if DNA is loosely wrapped around histone proteins, there's more DNA available for transcription, and DNA is tightly wrapped around the histone proteins, then less DNA is available for transcription. So if epigenetic factors, they bind to the tails of the histone proteins, that can alter the expression of the genes. So the histone proteins, if the histone proteins are acylated, DNA is loosely wrapped around the histone proteins and more transcription can take place. And if the histone proteins are deacylated, the DNA is more tightly wrapped around the histone proteins and less transcription will take place. So let's go over some of the basic concepts in molecular pathology. So let's see how the cancer develops at the molecular level. So there are three basic mechanisms. There can be an impairment of the control of cell division, and this is due to the loss of function of tumor special genes. Or there can be aberrant activation of pathways that stimulate cell proliferation. This is due to the gain of function mutation of proto-oncogenes. The third mechanism is where there is inactivation of pathways that lead to cell death. So follicular lymphoma, for example, there is activation of pathways that inhibit BCL2-mediated apoptosis. So when we talk about genomics in oncology, we talk about the genome of the patient and we talk about the genome of the tumor. So when we talk about the genome of the patient, we are talking about the constitutional or germline or inherited mutations. So these are the mutations that occur in gametes or the cells that produce gametes. So these mutations can be passed on to offspring. So medical geneticists are the physicians who identify and manage these patients, as these patients are at elevated risk of cancer development. On the other hand, when we talk about the genome of the tumor, we are talking about the somatic or acquired mutations. So these are the mutations that arise in tissues other than the germ cells. So these cannot be passed on to offspring. So molecular oncologists manage these patients. So pathologists, medical oncologists, radiation oncologists, surgical oncologists, we are the physicians who take care of these patients. Let's go over some of the most commonly used terminologies that we come across every day. So gene, as we discussed, is a piece of DNA that codes for protein. Locus is the street address of the gene on the chromosome. Where exactly it is located on the chromosome is the locus of that gene. So alleles are different versions of the same gene. So we inherit two copies of a gene, one from our father and one from our mother. So the genes that we inherit from our parents, these are the different copies of the same gene. So they are not 100% identical. They have some variations. So these are the alleles of the same gene. Wild type allele is the most common and functional allele. It is present most commonly in the wild and natural populations. So when we talk about sequence variations, there are two types of sequence variations. There's a mutation and a polymorphism. So mutation simply means change in the sequence of DNA, but when we use the term mutation in common usage, we are actually talking about a sequence change that is associated with a disease. So it is a disease-causing change. Polymorphism, on the other hand, when we talk about polymorphism, that's a sequence change that is not disease-causing. It is present in more than 1% of the population. So epigenetics, as we discussed, is the modification of gene expression without any change in the sequence of the DNA. So oncogenes versus tumor-specific genes. Oncogenes are mutated copies of proto-oncogenes. The normal function of proto-oncogenes is to regulate normal cellular growth, cell division, and apoptosis. So when oncogenes, which are the mutated copies of proto-oncogenes, when these proto-oncogenes are mutated, there will be aberrant activation of pathways that stimulate cell growth. So this is basically a gain of function mutation of proto-oncogenes. Tumor suppressor genes, on the other hand, they prevent cells from growing and dividing. So basically, tumor suppressor genes are brakes on cell division. So when a tumor suppressor gene is deleted or mutated, that means the brakes, we lose the brakes on cell division. So this is the loss of function mutation of tumor suppressor genes. So cells will continue to divide now. So for tumor suppressor genes, you need two hits, two independent mutations in a somatic cell. So as long as you have one functional copy, you will have some function. But in order to lose the function completely, you need to lose both copies. So familial cancers, for example, they have already inherited one defective copy. They only need a second mutation in the normal copy for the development of cancer. So driver versus passenger mutations. So driver mutations are the mutations that drive the cell to proliferate. They drive the cell to not die, or they drive the cell to resist therapy. These are the mutations that are actionable. These are the mutations which are the target of potential treatments. Passenger mutations, on the other hand, they do not have any particular effect on cancer. So these are the ones that are not actionable. So heterozygous versus homozygous. So being heterozygous means that you have inherited different versions of a gene or a genomic marker from each of the biological parents. On the other hand, homozygous means that you have inherited same versions of a genomic marker from each of the biological parents. So loss of heterozygosity. So basically, if a person is heterozygous for a genomic marker or a gene, that means they have inherited different versions or different copies of that genomic marker from each of the parents. So if that person loses one of the copies, that means that person has lost heterozygosity, meaning that he's only left with one copy, so he does not have the heterozygosity for that genomic marker anymore. Let's understand this concept from the example of Lee-Fraumeni patients. So Lee-Fraumeni syndrome patients, they have inherited one defective mutated TP53 copy from one of the parents, and they have inherited one normal copy from the other parent. So what happens is when these patients, when they're born, they do not have any cancers. But as they grow older, they eventually lose the normal copy, which leaves them with only the defective copy. Now, later in life, they will start to develop different types of cancers. SNP versus single nucleotide variant. So both of them are single nucleotide changes. The only difference is the frequency at which these changes are present in the population. Single nucleotide polymorphism, for example, is present in more than 1% of the population and is limited to germline DNA. The single nucleotide variant is a terminology for the single nucleotide change without any frequency limitation. So it can be either common or it can be rare. It can be either in the germline or it can be in the somatic cells. Let's go over some of the tissue requirements for solid tumor next generation sequencing. So tissue requirements and tissue metrics, they are totally dependent on the type of the test and the testing platform, and these requirements evolve over time too. So as we know, we have different types of molecular tests. We have small targeted panels and we have large comprehensive panels. In small targeted panels, we are testing small number of genes. So tissue requirements will be different for small panels and they will be different for the larger panels. Fish, on the other hand, is different because we are not extracting any DNA. So all we care about is that we have 100 cells and these 100 cells have intact architecture. We can see the boundaries of the cells because we have to count signals within the boundaries of the cells. So as long as architecture is intact and we have more than 100 cells, the specimen is adequate for fish. NGS, on the other hand, has two basic requirements. It needs adequate tumor cellularity and it needs adequate percentage of tumor nuclei. So as we discussed, there are different types of molecular tests. There are targeted panels and there are large comprehensive panels. For most targeted panels, where we are testing small number of genes, and even within those genes, we are testing the most frequently mutated of the hotspot regions. So these targeted small panels, they usually require 30 nanogram of total DNA. So if you have a 4x4 mm piece of tumor tissue, and you can prepare 10 unstained slides from this tissue, or if you have a cytology specimen and you have more than 5,000 cells, that specimen should be adequate for molecular testing. So that's the preferred or desirable requirement. But if you have at least a 3 by 1 mm area of tumor tissue, or if you have a cytology specimen where you have more than 3,000 cells, that specimen may potentially be also adequate for testing. So tumor percentage is the other requirement. You should know that every test has the limit of detection. So if you have a tumor specimen that has a very low percentage of tumor, then that percentage may be below the level of detection for that test. So in that case, there will be a risk of false negative result. The other important thing that you should be aware of regarding tumor percentage is that it's not the size of the cell or surface area of the cell. It is the ratio of the number of tumor cells to the number of background cells that matters. Because tumor cells are large, they are big and they have large surface area, so they will look big. But it's not the size of the nuclei that matters. It's the ratio of those tumor cells to the number of background cells that matters. So let's look at few scenarios. If you have a larger resection, and then obviously you have a larger piece of tissue available for molecular testing. And if you come across a situation, if in this larger piece of tissue, if you have a small overall percentage of tumor nuclei, you can do macro dissection. So by macro dissection, you are actually drawing a circle around your tumor. And by doing that, you're actually excluding the normal tissue, and you're excluding the areas of necrosis, or you're excluding the areas of lymphoid aggregate. So basically, you are increasing the percentage of tumor nuclei in that circle. So in that case, if the overall cellularity was low before macro dissection, in that case, after macro dissection, within the area of circle, the tumor percentage may be higher and the specimen may be adequate for testing. So in the second example, if you have a small tissue biopsy, in that case, macro dissection may not help you, because if you draw a circle around your tumor in a hope to increase the percentage of tumor nuclei within the circle, you will be able to do so, but at the cost of tumor cellularity, because you are essentially working with a very small amount of tissue. So because of low cellularity, that specimen will be inadequate for testing. Same goes for the cytology specimens. We have, even if we have cellular smears, those specimens may be inadequate if the tumor clusters are just few in number. Although those tumor clusters would be will have cells which will appear larger with larger surface area, but it's not again the number, the size of the cell, it's the ratio of tumor cells to the number of background cells that matters. So if you have just a few tumor clusters and most of the cellularity of the smears is due to the background inflammatory cells, so in that case the tumor percentage would be less than 5%, and then that specimen will be inadequate. So formalin is the most commonly used fixative. It does damage the DNA, but it is an acceptable specimen. All you have to make sure is that there is no inadequate or excessive fixation, because that will negatively impact the quality of DNA. Ethanol is a very good fixative for cytology specimens, and it does not damage DNA significantly. So for sure, this is an acceptable specimen. Decalcification or Bowens solutions, on the other hand, they are not acceptable. So before you send a specimen for NGS testing, make sure the specimen was not decalcified. So we should be aware of tissue artifacts too. So crush artifact or pottery artifact, it is very difficult to determine the percentage of nuclei if there is significant crush or pottery artifact. So these are not ideal specimens for NGS testing. So these specimens actually are also not good specimens for FISH testing, because you are not able to see the architecture of cells. You cannot define the boundaries of cells because you have to count the signals within the boundaries of the cells. So these specimens with significant crush artifact or significant pottery artifact are also not good for FISH testing. So tissue necrosis, if it's a small area of necrosis, you can exclude that area of necrosis by macro dissection. But if the tumor is extensively necrotic, so that's not adequate for molecular testing. Some elements like melanin or calcium, they inhibit PCR reaction, so you should be aware of that. So you can still try. Molecular testing on specimens with excessive melanin, but be aware of the fact that it may not work. Let's go over next generation sequencing. So sequencing basically means that you want to determine the exact sequence of nucleotides in the DNA. So before next generation sequencing, we used to have first generation sequencing, which was mostly Sanger sequencing. The problem with Sanger sequencing was that we could only sequence a single fragment of DNA at the same time. So the solution was next generation sequencing. So next generation sequencing is massively parallel, which means that we can sequence millions of fragments simultaneously in a single run. So next generation sequencing essentially has helped us sequence hundreds to thousands of genes at one time. And NGS also helps us with tissue conservation, because if you have single gene assays, you will need a lot more tissue for testing. But if you have next generation sequencing, you can sequence a lot of genes with a small amount of tissue. Because sometimes beyond molecular testing, you may need to do additional IHC testing on tissues. So if you have next generation sequencing, you can achieve more with less tissue. So Human Genome Project was completed in 2003. It took over 15 years, and it took more than $2-3 billion to complete the Human Genome Project. But today, we can sequence a full human genome in under less than $1,000. And if you follow the graph, you can see that there is a significant drop in the cost for sequencing. And this is when the Illumina introduced its sequencing platforms. So I wanted to go over the spectrum of clinical NGS testing in solid tumors. So as we discussed, there are multiple types of NGS tests. On one end of the spectrum, we have targeted panels. These are small panels. These have small number of genes, and even within those genes, we are looking for most frequently mutated hotspot regions. So these panels, these targeted panels, they are more aligned with the FDA-approved therapies. And next, we have expanded or comprehensive cancer panels. So these expanded cancer panels, they include hundreds of genes. They include all the druggable genes, they include all the oncogenes and all the tumor special genes. And these panels, in addition to the FDA-approved therapies, these panels are more aligned with the clinical trials and with the investigation of therapies. So on the other end of the spectrum, we have whole exome sequencing or whole genome sequencing. So for whole exome sequencing, we are sequencing all the coding regions, which are the exons of all the genes. And whole exome sequencing, when we are sequencing all the coding regions of the DNA, that is about 1% of the genome. So it's important for you to know that targeted panels may only be targeting a small number of genes, and they may only be identifying mutations or small insertions and deletions. They may not be detecting fusions or copy number changes or other types of genetic alterations. So on the other hand, the comprehensive panels may be detecting all the different types of genetic alterations. So next generation sequencing is performed on instruments like this. This is an example of MySeq instrument by Illumina. So sequencing is done on the flow cells. So these flow cells are like microscope slides, which have channels on the inside. So it's not as simple as that you have the tissue that you can load onto the flow cells and then sequence the DNA in those samples. So first you have to prepare your sample. So let's see how we prepare those samples. So the first step is that you have to extract the DNA, of course. So after you have extracted the DNA from the tissue, the DNA will be fragmented. So individual fragments, when you have those individual fragments, you add the adapter sequences to the ends of the fragments. So these adapter sequences, they have primer binding sites and they have capture sequences. So these capture sequences will allow these fragments to be captured onto the surface of the flow cell. So when you have captured these fragments onto the flow cells, the next step is that these fragments will be amplified into a clonal cluster. So in the individual cluster, all the fragments will be identical because they are coming from the same fragment. So once these fragments are amplified, the next step is to determine the sequence or order of nucleotides in these fragments from your sample. So you add fluorescently labeled nucleotides, and these nucleotides will be incorporated. And when these are incorporated, a picture is taken. So based on the emission wavelength and intensity, we will be able to identify which base was added. So the cycle is repeated multiple times, and by this process, you are able to determine the sequence of nucleotides in your sample. So once you have determined the sequence of nucleotides in your sample, you align these reads against a reference genome to identify if there is any change. So in this picture, you can see that you have a reference genome at the bottom, and you have multiple reads from one of the fragments that we just tested. And you can see that as compared to the reference genome, the nucleotide T, shown in red, has been replaced by the nucleotide C. So this is the mutation that you were able to detect in your sample. So a few important things that I wanted to highlight regarding NGS is that you should know the genetics of your tumor before you send the tissue for testing. You should know which genes are involved in that particular tumor type, and not just the genes that are involved in that tumor, but also the different types of genetic alterations that can occur in those genes in that particular tumor type. We should be aware of the testing guidelines for the molecular test. And we should also know that, as we discussed, there are different types of molecular tests. There are targeted panels, there are large comprehensive panels. So for example, we should know that the targeted panels, usually they will only detect mutations or small insertions and deletions. They will not be detecting fusions or copy number changes. So if you have, for example, a lung adenocarcinoma, so we know that in lung adenocarcinomas, there are EGFR mutations, or there are ALK or ROS fusions. So if you're sending lung tumor for testing, so you should know that the small panel will only be detecting mutations and it will not be detecting the fusions. So if you want to detect the fusions, you may have to send tissue separately for FISH if you're sending it for small targeted panel. So also, basic thing that the molecular test informs you about the therapeutics, but it also informs you about the diagnostics, and it can also provide you prognostic information. So as we discussed, we should be aware of the guidelines for molecular testing for the tumor that we are sending for NGS testing. For example, if you have only single gene assays available, and you are diagnosing and treating lung adenocarcinoma cases, so it is an absolute requirement that you should test for EGFR mutations, ALK and ROS fusions. But if you have NGS testing, comprehensive NGS testing, not just the targeted NGS testing, but if you have comprehensive NGS testing available, then you should test for additional genes that are involved in the pathogenesis of lung adenocarcinoma, and that would be BRAF, MET, RET, HER2, KRAS. So if you only have single gene assays available, then you can test for EGFR, ALK, and ROS. And in a case, if you do not identify any mutation in EGFR, or if you do not identify any ALK or ROS fusion, then you can do a KRAS mutation. And if you are able to find a KRAS mutation, then probably you may not need to test for additional genes, because KRAS mutations, because all these mutations or genetic alterations, these are mutually exclusive. So we should be aware of the testing guidelines before we send the tissue for NGS testing. So this is the genomic landscape of lung adenocarcinoma. So you can see that EGFR mutations account for 28% of the lung adenocarcinoma cases. KRAS mutations account for another 25.3% mutations. And then there are a number of other genes that are involved in the pathogenesis of lung adenocarcinoma. What I wanted to highlight here is that, as we discussed, we should know the genes that are involved in the pathogenesis of the tumor that we are sending for testing, but we should also know the different types of alterations in those genes. For example, you can see that HER2 gene is involved in lung adenocarcinoma. And you can see that HER2 amplification accounts for 1.4% of lung adenocarcinoma cases. And HER2 mutations account for another 2.3% of lung adenocarcinoma patients. So if you're sending it for an NGS test that only looks at mutations, so you will be able to detect mutations, but you will not be able to detect fusions. So we need to know the limitations of the test that we are sending our specimen for. Let's look at the molecular pathology report and see how we interpret different components in that molecular pathology report. So molecular pathology report will tell you all the different types of genetic alterations that were detected by the test and in which genes those mutations were detected. So these mutations can be, depending on the test, it may be sequence variations or it may be sequence variations and as well as structural variations. So also the molecular test will describe the sequence variations both at the DNA level and also at the protein level using a standard nomenclature. So we will go over this nomenclature, how these alterations are described by the molecular test. So molecular test will also give you the variant allele frequency, meaning that it will tell you at which frequency the variants were detected by the test. And the last thing is that the NGS test will also inform you about the clinical significance of those variants. So somatic variants, they are classified depending on the level of clinical significance. They're classified or categorized using a 4-tiered classification system. So the variants that are of strong clinical significance, these will be classified as tier 1 variants, and the variants that have potential clinical significance, these variants will be classified as tier 2 variants, and so on. And tier 4 variants will be benign or likely benign variants. So in addition to the different genetic alterations the molecular test is reporting, the comprehensive panels also give you some additional information. So comprehensive test will give you the microsatellite status and tumor mutation burden status. So these two are biomarkers for immunotherapy. If a tumor mutation burden is high, or if the tumor is microsatellite and unstable, those tumors can be candidates for immunotherapy. So when we talk about genetic alterations, we can broadly look at these genetic alterations as either sequence variations or structural variations. So sequence variations, as we discussed, are mutations, different kinds of mutations, and small insertions and deletions. And we will go over these sequence variations in the next slides. And structural variations, on the other hand, include copy number variations such as amplifications or deletions, and they include chromosomal translocations or interstitial deletions or inversions within the chromosomes. So structural variations basically affect larger segments of DNA. So among the sequence variations, so silent mutation is when there is a nucleotide change. So when there is a nucleotide change, it will change the codon. But if the new codon is still coding for the same amino acid, this will be a silent mutation. On the other hand, if the nucleotide change results in a new codon and this new codon codes for a different amino acid, then that would be a missense mutation. And nonsense mutation is when a sequence change results in a stop codon. So that would be a nonsense mutation that will lead to the truncated protein. So deletions and insertions are simply additions and deletions of one or more nucleotides into the segment of DNA. Indels, or deletion insertions, they are mutations where one or more nucleotides are deleted and replaced by other nucleotides. So as we discussed, codons are a set of 3 consecutive nucleotides. So the reading frame it is read in the form of codons. So if there is a deletion of at least 3 nucleotides, or the deletion is a number that is multiple of 3, then the reading frame is not disrupted. So that's an in-frame deletion. Similarly, if the nucleotides that are added are at least 3 or a multiple of 3, then the reading frame is not disrupted, and then that insertion would be an in-frame deletion. As compared to the in-frame deletions and insertions, if the nucleotides that are added or deleted are not multiple of 3, that will result in the disruption of reading frame. So that will be a frame shift mutation. So the consequence is that downstream of the amino acid, which was affected by this deletion or insertion, there will be a stop codon, and that will lead to a truncated protein. Splice site mutation is another type of mutation. So as we discussed earlier, that introns are spliced out during post-transcription modification. So the boundary of the exons and introns is called the splice site. So the 5' end of the intron is the splice donor side, and it always has a GT sequence, and a 3' end of an intron is a splice acceptor site, and it always has an AG sequence. So whenever there is a mutation at the splice site, the consequence is that during the process of splicing, the splice site would not be recognized. So the consequence is that not just the introns, but the whole exon may be spliced out along with the intron. In terms of structural variants, we have translocation. So basically, there are 2 chromosomes that have breaks, and the fragmented pieces from these 2 chromosomes will reattach to the different chromosomes. Interstitial deletions, on the other hand, there are 2 breaks within the same chromosomes, and within the same chromosome, and the 2 broken ends will fuse together, and the intervening segment of the DNA of the chromosome is lost. Inversion is another type of structural variation in which a chromosome breaks at 2 points and reattaches, but it reattaches in the reverse orientation. So after discussing the genetic alterations that will be described by the molecular test, we should know how the nucleotides are numbered, because sequence variations are reported in the molecular test by they are reported using a standard nomenclature, both at the DNA level and both at the protein level. So nucleotides are numbered in a specific way. So first nucleotide in exon 1 will be numbered as number 1 nucleotide. So in this example, as shown by the black bar, the first exon has 36 nucleotides. So the first nucleotide in this exon would be number 1 nucleotide, and the last nucleotide in this exon would be 36 nucleotide. The numbering then resumes with the first nucleotide of the second exon. And for the nucleotides upstream of the exon 1, the numbering would be -1, -2, and so on. So the first nucleotide upstream of the exon 1 would be numbered as -1. And the second nucleotide upstream of the exon 1 would be numbered as -2, and so on. For introns, the nucleotide downstream of the 3' end of the exon would be numbered as +1. And the second nucleotide would be as +2. And similarly, the nucleotides upstream of the 5' end of the exon, second exon, would be numbered as -1, -2, and so on. Let's look at some of the examples. So the sequence variations are reported using a standard nomenclature. So if there is a nucleotide at position 576 that is replaced by A, so this will result in a new codon, but the new codon is still coding for the same amino acid. So at the protein level, P dot glutamine is still the same, because the new codon is still coding for the glutamine, because we know that more than 1 codons can code for the same amino acid. Second example in this table, so at this position, for 254, the nucleotide G has been replaced by A. So now we have a new codon which codes for a different protein. So at the protein level, the nomenclature would be P dot glycine at position 85 replaced by glutamic acid. So new codon is coding for glutamic acid. The third example is that we have a nucleotide T at position 1624. So this has been, so we have a nucleotide G at position 1624, and this has been replaced by T. So as a result of this nucleotide change, the new codon is a stop codon. So previously the codon was coding for the amino acid glycine, and now this is replaced by a stop codon. So another example is that we have three nucleotides at position 1521, 1522, and 1523, and these three nucleotides are deleted. So since the deletion is a multiple of 3, so this is an in-frame deletion. So the way that it is described is that the first nucleotide that is deleted is at position 1521, and the last nucleotide that is deleted is at position 1523. So underscore basically gives you the range. So simply it means at the nucleotide level or DNA level, it's C dot 1521 underscore 1523 is basically 3 nucleotides are deleted, and since they are a multiple of 3, the entire amino acid is deleted. Reading frame is not disrupted, so this is an in-frame deletion. As compared to the in-frame deletion, if the nucleotide T, which is at position 948, if it is deleted, so it's not a multiple of 3, so that means the reading frame will be shifted. So before this nucleotide change, the amino acid at this position was phenylalanine. So now as a result of this deletion, the new codon that will be coding for the amino acid leucine. So at the protein level, phenylalanine, which was at position 316, is now replaced by leucine. So the other consequence of this frame shift mutation is downstream of this leucine amino acid, there will be a generation of stop codon. So this will result in a truncated protein. So let's look at some more examples regarding the nomenclature. So in this example, there is a nucleotide at position 76. And downstream, we have two nucleotides, 82 and 83, shown in green and red. So these, for example, if these two nucleotides are deleted, the way we will describe it using the standard nomenclature, so we will describe this change as C dot 82 underscore 83, because 82 simply is the first nucleotide that is affected, and 83 is the last nucleotide in this example that is deleted, and underscore is simply the range. So the two nucleotides are deleted, so the way we will describe it is that 82 underscore 83, this nucleotides in this range are deleted, and they were the T and G. The second example is basically an example of indel. As we discussed, indels are the changes in which one or few nucleotides are deleted and they are replaced by other nucleotides. So in this example, A nucleotide is at the position 106, and downstream we have a deletion of 6 nucleotides. So at the nucleotides that were at position 112 to 117, they are deleted. So 6 nucleotides are deleted and they are replaced by 2 nucleotides, T and G, shown in the green. So the way we describe this in DEL using the standard nomenclature is that we again give the range. So 112 is the position of the first nucleotide that was deleted, and 117 is the last nucleotide that was deleted, and underscore is the range. So C dot 112 underscore 117 and deletion of 6 nucleotides, and we can specify those nucleotides, and we can also specify that they were replaced by the insertion of T and G. Or we can simply write this change as 112 underscore 117 replaced by TG. So the other piece of information that we get from the molecular testing is that the test will tell you the variant allele frequency. It will tell you the frequency at which the variant was detected. So one of the important informations that we get from VAF is the disease burden. So if the test tells you that the variant allele frequency is 15%, that means the tissue has neoplastic disease burden of 30%. So we know that all the normal cells have 2 copies of normal gene. So tumor cells also have two copies of the gene. One is obviously mutated, but the other one is normal. So if variant allele frequency is 15%, that means there are 30% tumor cells that have variant allele. Another information that we can infer from the variant allele frequency in our molecular testing is that we can use this to potentially classify variant as a germline or a somatic variant. So for example, germline variants, we know if they are heterozygous variants, the allele frequency should be 50%. Or if the germline variants, if the VAF is 100%, then the variant is a homozygous variant. So in the real world, practical world, it's never like exactly 50% or 100%. So if you have a variant that is between the range of 40% and 60%, so that can potentially be a germline variant. The variant allele frequency also can help us distinguish driver mutations from passenger mutations, because driver mutations obviously will have much higher variant allele frequency than the passenger mutations. So the last piece of information that we get from our molecular reports is the clinical significance of the variants that were detected by the test. So somatic variants are classified or categorized depending on the level of clinical significance into 4 tiers. So the variants that are of the strongest clinical significance are classified as tier 1 variants. And these are the variants that have an FDA approved therapy, or these are the variants that are included for diagnostic, therapeutic, or prognostic purposes in the professional guidelines. So tier 2 variants are the variants that are of potential clinical significance, meaning that FDA has approved a therapy for the variant, but in a different tumor type. And if you use that drug off label for a different tumor, so that would be the variant that has a potential clinical significance. Also, the variants that can qualify patients for clinical trials or the variants that have some drugs in preclinical studies, these can also be classified as tier 2 variants. So tier 3 variants are the variants that are of unknown clinical significance, meaning that these are not present in population at a frequency of 1%. So they are not present in population. They are not present in more than 1% of population, and these are not associated. They are not reported in any cancer databases, and these do not have any convincing published evidence of association with cancer. And tier 4 are the variants which are benign or likely benign. So also although we classify these variants into 4 classes, but tier 4 is not reported in the somatic cancer reports. So this is all that I have for you. I hope you would be able to read the language of genetics a little bit better now and would be able to explore the world of molecular pathology on your own. Thank you so much for your time.
Thank you, Dr. Ibrahim, for such a fantastic presentation. I think it's such a vast topic, and you have very professionally summed it up in an hour, which is a very difficult task in itself. But I think that was a very good presentation about the basis of the molecular, and especially for the residents and for the pathologists as well, who don't have much experience regarding the molecular testing. So it is very important that not only that you know that what molecular testing has to be done, but it is also very important that how it has to be done. So our next session is for neuropathology. We are having a bit of technical difficulty starting the next one. So before I start, let me see if Dr. Junaid is here with us. And we have a few questions regarding for Dr. Junaid. So Dr. Junaid, are you all right if we'll start with your questions first and then you'll be free? I am.
Yes, thank you so much. Yeah, no problem. We can go over the questions.
What's the time there, first of all? What time are you out?
It is 6 a.m. Not too early. It's about the time to get ready and go to work.
So thank you for being with us at such odd times. So I'll start with a question. First of all, first question is, which specimen do you think is preferable for molecular testing, paraffin-embedded tissue blocks or cytology?
So I think both are obviously it's I think the question is like which is better, but I think it is which is available. So I think most commonly available tissue is paraffin embedded tissue block. So it's not if you have cytology, I mean, it's so paraffin embedded tissues are acceptable. They are not the best specimens, but obviously they are the most widely available specimens. So if you have cytology specimen, and if it meets the criteria for tissue percentage and tissue cellularity, obviously that ideally would be a little better specimen and that would give you a better quality DNA. But I think the question is not about which one is better. I think which one is available. So paraffin embedded tissue is going to be the one by far the most common specimen that would be available, and that would be okay using it.
So basically, sensitivity-wise, both are equally good. It's just
Yeah, so it's so all the NGS tests, they obviously are validated using all the different kinds of specimens. So they have the tissue formalin fixed tissues, they have the cytology, they have the blood, they have the cell lines, and everything is validated. So if it has been validated for the tissue, that we should be able to um, accept the results for that tissue.
right. Next question is, do you have a separate NGS panel for gliomas? If yes, then what mutations do you offer?
So I think that question we can save it for the next presenter. It's not basically it depends on the centers what kind of cancers they are treating and operating and getting the specimens on, and then as I said in my talk too, we need to know the genetics of the tumor before we test it. So you need, if you are testing treating neuropathology specimens, so you need to know which genes are involved in these gliomas. So yes, definitely you can have, and people have targeted NGS panels for gliomas and all different kinds of tumors. So it depends on what is the volume of gliomas that you have at your center, and then you go from there.
Right. Tissue versus blood for NGS. Blood is also being used as a specimen for NGS. So what do you think would be prefer? Again, the same question, I think, is it tissue preferable or the NGS performing or the blood specimen is preferable?
So tissue, you know, obviously the liquid biopsy or the blood usage of blood for NGS. So I think it's usually the tumors that have high burden. They have more circulating tumor DNA in the blood, and those are the specimens that will give you a good yield. So tissue versus blood. Basically, I mean, the basic thing that you need to understand is that even if it's a small amount of tissue, a small amount of tumor tissue, it will still be shedding circulating tumor DNA in the blood. It's about the ability of the test to detect at which level it can detect the circulating tumor DNA. So at this thing is evolving. So over the period of time, we will have tests which will have better sensitivity. Mostly, I think the people go for blood if it's difficult to get the tissue for the testing, and also for the I think the residual disease burden after treatment. So those kinds of tests, basically the liquid biopsies are, at this point, the purpose of the tests is either you're not able to get the tissue, or you're testing, you already know the mutations of the tumor. You have already treated the tumor for those mutations, and then you are looking for the residual disease burden for those. But in the future, obviously, the sensitivity, the limit of detection would get better, and then probably blood can be potentially used as the first thing.
I think in our setting, especially if I talk about lung, the problem we face with the lung is that usually most of the tissue is subjected to diagnostic immunohistochemistry. And by the time the diagnosis is reached, the yield of the tissue is very much less than what is being required for the molecular. And then the clinician have no choice but to just go for the blood NGS because biopsy is not easy most of the time with the patient. All right. Right. Do you perform lung molecular panel on all patients, or is there any prioritization of patient for these tests? I think that, yeah, Dr. Junaid can answer.
Yeah, so as we discussed, we need to know the guidelines for testing. So for the lung cancers, we do testing for lung adenocarcinomas or any carcinoma that has a lung adeno component. Or sometimes we also can do testing on squamous cell carcinomas if the patient has never smoker or minimal smoker. I would actually suggest or ask residents to explore the NCCN guidelines. You can create a free account and you can just you can start from lung if you want. You can go through the NCCN guidelines and it will clearly tell you all the details step by step, different stage of the tumor and what are the next steps. And that will include the molecular testing guidelines too. So they may not be 100% aligned with the FDA, but like those are the ones which are the professional guidelines. So I think so we do not, obviously if it's a small cell carcinoma you won't test it. You have to have adenocarcinoma or any mixed adeno plus any other component. And squamous, obviously sometimes you will get a request from the oncologist on squamous too, but those would be like never smoker, minimally smoker patients. And then also I think sometimes there may be some exceptions too. If they are looking for they just want to find something to treat. If it's like widely metastatic and nothing is working, so they may try to send that test for broad testing in a hope to find some mutation which has a FDA approved therapy, maybe off label or something.
Right. One question from my side that we know that for the lung adenocarcinomas, the preferred HER2 testing, as you explained in your presentation as well, is that it depends what kind of a testing you want to do. But we often get the request that they want to do HER2 through IHC. So how significant is reporting the HER2 on lung adenocarcinoma through IHC?
It's a very common request. I think now with even if I think I'm not 100% aware of any FDA approved therapy for HER2 alterations in lung carcinoma, but again same thing, HER2 alterations in breast, for example, obviously they have FDA approved therapy. So if the goal is to use off-label drug which is approved in breast, if they want to use it in lung, that may be one reason. And if other therapies are not working, but we get those requests too from bladder cancers and all that. So I think this is like every day there is a new drug and there is no new trial and there is no new preclinical study. So there is something out there which that oncologist may be more aware of than we are. But I think they always have some reason. So if they're asking for IHC on lung, I think I have to update myself too. There may be something out there.
Right, because I was just looking through the CAP guidelines, the CAP reporting protocols for the lung biomarkers, and they do include HER2 IHC as a part of HER2 testing. But I couldn't find like real guidelines. I assume that they are reported like just like breast 2+ and 3+, and the criteria is also the same.
Or the stomach, gastric report.
Gastric,
G junction.
for the lung itself, I'm not sure that, is it reported like breast, and should we do for 2+, then we will send it to the fish, and what the protocol for that is?
Yes, I think it may be the way the gastric tumors are reported for it. The HER2 is reported in gastric tumors.
All right. That's excellent. All right. Thank you so much, Dr. Junaid. Thank you for being with us at this odd hours of the day. And thank you for the excellent presentation. I think those are all the questions we have from you. So now you can go ahead and go ahead with your day, and we'll go on to the next presentation. Thank you.
Thank you so much.
Now for next presentation, we'll just take a 5-minute break, and then we'll come back to it. Thank you. Right. So, So now with this, we'll just go ahead with our last presentation, that is by Dr. Stewart G. Neal. He's a board-certified neuropathologist. He has clinical interest in the neuro-oncology, and his primary research interest is in the utilization of genomics to assist in diagnosis and treatment of central nervous system neoplasia. Dr. Neal is an assistant professor of pathology at Emory University School of Medicine, USA, and we'll go ahead with this presentation. And we'll have the question and answer session at the end of this presentation. Thank you.
Hi, my name's Stuart Neal. I'm a neuropathologist here at Emory University, here to talk to you about the morphological examination of gliomas in adults in the era of molecular neuropathology. This is me. I don't have any conflicts of interest to report to you. Thank you so much for inviting me. It's a real honor to have this opportunity. What are we going to be talking about today? We'll be reviewing the history and current state of diagnostic practice of surgical neuropathology, particularly as it regards to adult gliomas. We'll be discussing the use and balance of the clinical pathologic, morphologic, and genomic information that we use in surgical neuropath practice. It's a lot of different data streams. We have to weave them all together and sort out how best to arrive at a diagnosis. And to sort of explore this some more, we'll be going through some cases, looking how the 2021 CNS WHO guidelines and some of the information that we deal with impacts our diagnostic approach. So first, we'll briefly overview the current state of diagnostics for CNS neoplasia. So first, a brief history of CNS tumor diagnostics. So as with many solid tumors, surgical pathology pertaining to solid tumor diagnostics is, in surgical neuropath was similar to pathology elsewhere in the body. It's been based on histopathologic findings in combination with clinical and radiographic features. And in particular, as regards to CNS, you need to know where you are. So the location of where you are in the CNS really impacts what your differential diagnosis is going to be. And you kind of take that in context with what the age of the patient is, what the presentation is, to help figure out what your primary differential is. And with these tools, we've been diagnosing cases reliably with minimal ancillary studies for many years. Now, there have been some well-known areas of diagnostic uncertainty. However, in a lot of circumstances, limitations in treatment made it such that those areas of diagnostic uncertainty were really not always that relevant. So when we're talking about location-based differential diagnosis, this is what we're talking about. There are certain areas in the CNS that are well associated with specific diagnostic categories. For instance, medulloblastoma being found in the cerebellum, pituitary adenoma being found in the pituitary region, gliomas found in the cerebral hemispheres, for instance, schwannomas found at the cerebellopontine angle, and on and on and on. So you always need to know where you are, and that is helps you refine your differential diagnosis. And this is a classic image of a table basically laying out some of these location-based differential diagnosis. And I want to point out to you that many of these diagnoses were also determined based upon what age of the patient was. So some of these terms that you'll see here are no longer used, but many of them still are, and this still forms the bedrock of a lot of our practice. Now, I mentioned some diagnostic uncertainty, though, and there were specific areas of surgical neuropathology where there's been substantial diagnostic uncertainty in the past, a lot of inter-observer variability. Some of this had to do with pre-test variables, things like how big were the samples that we could usually generate from these areas. And then, of course, testing variables, different diagnostic schema, and how these diagnostic schema were applied in different circumstances. There were several studies from the pre-molecular era that noted high inter-observer variability in the morphologic classifications of infiltrating gliomas, for instance. And this wasn't just inter-observer variability, it could be inter-institutional variability. Overall, there was roughly 20 to 40% disagreement, and 10 to 15% serious discordance based on the studies from that era. And yeah, this is a really unfortunate situation because, of course, some of these tumors are really clinically problematic. You know, you had patients who were getting deadly diagnoses and then going to different institutions, potentially for clinical trials, for different therapeutics, and we're getting different diagnoses, which just made people really frustrated and led to a lack of trust in some circumstances with what we were doing. So I always like to highlight this older study that showed in one study of infiltrating gliomas that there were 76% agreement on astrocytomas, 69% agreement of oligodendrogliomas, and only 13% agreement amongst these neuropathologists in the study regarding the diagnosis of oligoastrocytoma. And come to find out, the diagnosis of oligoastrocytoma was really not a true entity in most circumstances. What we were doing was attaching a morphologic descriptor to a group of entities, not as opposed to a single thing. So we now know well that diagnostic uncertainty and inter-observer variability can be reduced through the incorporation of genomic findings into our evaluations. So the WHO has taken a number of steps to incorporate genomic findings into the WHO guidelines. There are certain genomic features that are essential to some CNS tumor diagnoses. This is, I'm sure, not new to any of you. The genomic features can also reveal relevant tumor types and subtypes. And there are in the 2021 CNS WHO guidelines, there are some diagnoses that are only possible using very specialized testing, testing that is only available in a few institutions, for instance. Now, the WHO doesn't necessarily mandate specific types of like a specific platform of testing. So that has led to some variability in the approach to these diagnoses. And of course, there's some circumstances where this testing is really not available and the testing itself carries a lot of expense. So there's a wide variety of approaches to how we deal with this circumstance. I'm just going to go through first how we've approached this at Emory. So you see a number of different laboratories pursuing a range of approaches to detect some of the aberrations that you need to detect in order to make some of these diagnoses. Immunohistochemistry, of course, very widely available, a lot in some circumstances. Sequencing or PCR-based methods are used at some labs. FISH is utilized in a lot of labs. Microarrays, chromosomal microarrays are used in some laboratories. And then the testing that I was referencing earlier that is really still restricted to a certain smaller number of laboratories here in the US and Europe in particular is the methylation-based profiling. So that's there's certain diagnoses that are based upon methylation profiling, and you have to figure out, well, when do I need to make that diagnosis, or how am I going to even try to get access to that type of testing? So the exact panels, of course, are related to the practice environment, available resources, and system preference. And I've just bolded here the testing that we run at Emory. For instance, we do not have a methylation array to perform that type of profiling, and it's not available in the southeastern United States for referral laboratory use at this time. So we do use a lot of immunohistochemistry, and I've listed some of the key IHC stains that we use in the neuropathologic assessment of gliomas on this slide. There's, of course, some well-established stains, GFAP, synaptophysin, EMA, neurofilament, NUN sometimes to look for things like neurocytomas we would utilize. CD34 for the workup of some low-grade gliomas can be very helpful. Ki67, a really reliable stain to look for proliferative activity. And then P53, long-time stain that continues to find new uses in and helping try to tease out specific molecular subtypes. More recent stains that have been adopted, OLIG2, quite useful, a nuclear marker for glial differentiation. SOX10, somewhat similar to OLIG2 in some uses, though it also can be applied outside of the CNS in a number of different ways. And then IDH1, great thing about this stain, that it stains for the mutant protein for IDH1 R132H, and that one single mutation accounts for about 90% of all IDH mutations found in gliomas. So basically, just with that one stain, you're going to be able to pick up about 90% of the IDH mutant gliomas that you would encounter. It's a great stain, super useful. ATRX is another really useful stain for the workup of gliomas. It helps assess for mutations that lead to loss of ATRX expression, and that can help you tease apart certain diagnostic categories of gliomas, and assess also for the alternative lengthening of telomeres pathway. And then K27M and H3K27ME3, those are some useful stains to assess for some pretty rare gliomas, the histone mutant gliomas. We'll talk about in just a little bit, but another way of assessing a genomic alteration specifically through immunohistochemistry. Our glioma panel here at Emory is IDH1, ATRX, P53. We apply that to every single glioma that we see. It helps us pick up our IDH mutations, but also ATRX and P53 help you pick up maybe some gliomas that you wouldn't necessarily be expecting. Helps tease out a differential for a number of things that so much so that we apply it to every case. So we've talked a lot about genomics already, right? Trying to bring us all onto the same page of how practice occurs in my institution, for instance. But what role does morphology play now? Well, it's critical. It's essential for what we do. It really helps you determine a differential diagnosis. Even if you can't make a specific diagnosis morphologically, you have to know what you're looking at in order to gain context for the data derived from any additional testing that you might be pursuing. And of course, some common neoplastic entities, particularly in adults, remain possible to confidently diagnose by morphology, particularly alongside some immunohistochemistry. We'll go through some cases where really you're in good hands with just dealing with morphology, maybe with just a couple of key immunohistochemical stains. And the key role of morphology to me is really reinforced by the fact that we continue to learn more about morphology by doing the genomic testing. Understanding what some of the genomic alterations are, recognizing that, okay, these things are different based upon a genomic assay, then allows you to look at those cases more carefully and perhaps pick up on some morphologic findings that help you distinguish them from other things. So, we continue to move along in terms of our ability to detect changes via morphology. So let's go through a few more observations I can offer you based upon some practice in this context. I practice almost entirely in adult surgical neuropathology. We deal with a lot of cases here, very busy neurosurgical service. I see cases from across the CNS and the peripheral nervous system. So try to offer a few observations that maybe will help guide us as we continue to talk through the cases. So differential diagnosis is key. It's of course how we train our residents is how to generate a differential. It's not just getting to the diagnosis, it's thinking about the differential. And that's really important for recognizing situations where the information that you have at hand is incomplete. And then you have to learn how you phrase your communications to fit that state of knowledge. It's true all the time. That's the practice of medicine from my perspective, is understanding what I know, what I don't know, and how do I achieve adequate patient care while recognizing that, well, there are certain things that I'm not aware of or potentially don't have in hand at this point. Some diagnoses require comprehensive molecular testing, but the differential diagnosis can be informed by a clinical radiographic, morphologic, and immunohistochemical assessment. A lot of the same things we've been doing for a very long time. And in a lot of cases, that differential diagnosis can narrow it down enough so that we can still achieve an adequate treatment plan for the patient. So how do you achieve that adequate treatment plan? It's a team sport, right? Surgeons and oncologists can help you ascertain your needs for testing and reporting. We're always talking with our surgeons and oncologists about, here's kind of what we're thinking, but we're either going to send for this testing, or we're waiting on that testing, or for instance, we can't perform that testing for a variety of different reasons, and here, how's that going to impact what you do moving forward? So it's a team sport. You're always dealing with one another to do what's best for the patient. Sometimes that means that you utilize descriptive diagnoses, things like low-grade glioma, infiltrating glioma, high-grade glioma. If you need to report a case that you haven't fully worked up, you can't fully work it up, and in that circumstance, again, you're just giving an explanatory comment, talking about the differential diagnosis, perhaps favoring one thing, saying, based upon the patient's age, the behavior of the lesion, imaging features, so forth, I feel that I favor this type of lesion, but without doing certain testing, I can't completely exclude something else. Again, it comes down to the care of the patient, right? It's not just a purely academic exercise. We're dealing with real people. And you have to know, okay, is that incomplete, quote unquote, incomplete diagnosis, high-grade glioma, is that going to affect treatment at all? In a lot of cases, probably not. So we'll talk about a few circumstances where that's true here in just a few minutes. But it's also, you need to know, well, some of these newer diagnostic categories, particularly as regards methylation, if it's only available at a few centers, well, that means that most people around the world are practicing in circumstances where they're not going to have access to that type of diagnostic, that type of diagnostic. They're not going to see that diagnostic category. And so there's, because of that, the limitations of that testing at this point, it's really hard to define treatment regimens for some of these things just because the numbers are so low. So it's recognizing what that means for the patient is always going to be first in mind. So practice is a product of context. That's universal. And how do we maintain that line of communication with our surgeons and oncologists? Well, multidisciplinary tumor boards can be a really handy way of talking through these differentials and what they imply for the patient. So as you're working through these differential diagnoses, I think it's important to distinguish the impact of different types of findings. And so when I teach residents a lot, I talk a lot about how you want to distinguish single finding results from broader spectrum results. So single finding results with things like a single morphologic feature or a single immunohistochemical stain, a single mutation. It's, sometimes tumors can do all kinds of different things. So they may express an immunohistochemical, a protein detected immunohistochemically that, well, they're not supposed to do that. Well, it did it in this circumstance, right? So the single finding results are in many cases less impactful for how your your differential diagnosis is put together than your broader spectrum results. From my perspective, overall morphology is a broad spectrum result. Something makes the tumor look the way they do for a reason. And remember, when you're looking at a slide, that's a ton of data coming in. You're looking at, of course, not just nuclear size, shape, hyperchromasia, so forth. You're also looking at the architecture of the lesion, infiltrative nature of it, its relationship with the rest of the organ, so on and so forth. IHC panels, another broad spectrum result. You're looking at multiple different data points. And then, of course, broad spectrum genomic testing is a lot of the current in vogue aspect, but it fits in with everything else. I want to bring up the fact that, to me, the fact that morphology is a broad spectrum assay makes me excited for what we're going to be able to do with AI-based radiographic and pathologic image analysis to suggest molecular features. I remember when I was first learning about some of the different genomic subtypes of gliomas, I was taught by my attendings, well, you just can't tell by looking at them. You can't tell what the different molecular features are. But then over time, as again, people started to see more of them, they started to do more studies of them. Well, surprise, surprise, they started finding morphologic features that might suggest a specific molecular genotype. Maybe not 100%, but you can, the more you do this, the more you can kind of suss out. For instance, IDH mutant gliomas tend to have a lot of rounded tumor nuclei. And surprise, surprise, well, oligodendrogliomas are IDH mutant, right? And then a lot of those oligoastrocytomas I was mentioning, well, they are largely IDH mutant tumors as well. So, it's not that people were, it's not that the people looking at the slides for as long as they've done were totally fools, or that they lacked the ability to cognate or something like that. It was really just that it's the tools. The more the tools you have, the more you can suss out about what some of the key distinctions are. So it's important to note that some single finding results may be associated with specific therapies, though, things like BRAF V600E or PD-L1, something along those lines. So really, the bottom line here, molecular testing, important component of practice, but it's not replaced all of our traditional methods. It's important to be able to function without molecular data. You have to just know what the degree of uncertainty is based upon the data that you have available. And you know, it means we can't put our brains on a shelf while we wait for the molecular data to return. We have to be able to think, okay, what do we think this is, and what are the possibilities for what it could be? So let's talk through how we utilize some of these different methods, and I'm going to emphasize again morphology and immunohistochemistry as we work through some of these cases. So first case. So woman in her 70s presents with headache, nausea, vomiting, large ring enhancing or rim enhancing front mass in the right frontal brain. And this is an image that that's pretty characteristic of an infiltrating glioma. You can see that there is a gradient of cellularity across from the lower left-hand corner of the picture up to the upper right-hand corner of the picture. And that gradient of cellularity is a reflection of the fact that there are individual tumor cells that are able to infiltrate the background brain. They can winnow their way through the neuropil independently, and they have tendencies to aggregate around vessels, around neurons, so forth, showing you the typical behavior of an infiltrating glioma. So infiltrating glioma, let's look around some more. Now we know we have rim or ring enhancement here. And so it shouldn't be too much of a surprise to find foci of tumor necrosis. This is a higher power image, of course, with some necrosis here in the center. You can see some keryerectic debris scattered around, and then a vague palisade around the edge of this necrosis. So we're starting to put together older patient, ring enhancing mass, infiltrating glioma with foci of tumor necrosis, has an astrocytic morphology as well. And so we're basically thinking glioblastoma, right? The context fits, the morphology fits. When I was early in my practice, we basically made this diagnosis at frozen section. We would just say it flat out. Nowadays we know that, well, part of the WHO, you have to exclude an IDH mutation, so we do have to do that. But that's certainly what we're still thinking. It's not that the tumors changed because the WHO changed. It's just a little bit of extra work at this point. So, you know, when we're molecularly working these things up, we would know that, for instance, glioblastomas have a particular copy number signature. They oftentimes have a gain of chromosome 7, loss of chromosome 10. They may have an amplification of the EGFR gene. All of these things can help you in the diagnosis. However, in this circumstance, we pretty much already know what we're dealing with. In our practice, we do work these up molecularly. So I'm just going to expose you, going to talk briefly through some chromosomal microarray data. This will be more important for some of the cases later on, but in this case, what we see is here is a normal two chromosome copy plot here. We see that this is what I call a rainbow sherbet plot with the red, the green, and the orange, different the way the different chromosomes are displayed. So this is chromosome 1, 2, 3, 4, 5, 6, 7 laid out in a line, and we can see that here chromosome 7, this smooth signal, this averaging out of where the copy number probes are, is above where most of the rest of the chromosomes are. There's a gain of chromosome 7, and then over here, this smooth signal is below where the rest of the chromosomes are. So there's a loss of chromosome 10. And then there's a little spike actually right at EGFR. So this is showing us some of the classic copy number features of glioblastoma. Now, in this circumstance, though, the main thing we want to know is what is the IDH status of the tumor? And we can confidently assess that via IDH1 immunohistochemistry. Tumors with this histology found in patients with this age group that are negative for this immunostain can be regarded as IDH wild type. Most tumors with this histology in patients over the age of 55 will be IDH wild type. In this case, the IDH1 IHC was negative. So we've got our copy number data here. We've done all that workup, and of course, with in the context that I practice in, our surgeons, clinicians do look for this data. And if we were running methylation profiling, we would know that these IDH wild type glioblastomas tend to group together via methylation profiling as well. But these types of testing are not strictly necessary for the diagnosis in this setting. You basically would just need the IHC. So with that being negative, you could diagnose this as a glioblastoma IDH wild type CNS WHO grade 4. The term glioblastoma implies an IDH wild type tumor at this point, and there is a presumed molecular identity of that tumor, whether you're directly testing for it or not. Y'all know this is a very poor prognosis diagnosis, very difficult to treat. This is a mainstay of treatment. It remains surgical resection, radiation, and Timidar or temozolomide-based chemotherapy. That the treatment approach can be affected by the presence of MGMT methylation, but many of the observable genomic alterations in these tumors don't dictate changes in treatment, particularly in the setting of initial therapy. Some genomic findings may aid in placement for clinical trials, or there are some very uncommon circumstances in which targeted therapy may be attempted for these tumors. So, second case, another infiltrating frontal or frontoparietal mass. This one in a 60 man in his 60s, and this one also has some focal enhancement on MRI. Also, another infiltrating glioma. So we can see here we can see some neurons scattered over here, more on the right side of the image. Very cellular tumor here on the left side of the image, with some vascularity to it. But what we're not really seeing necrosis, and we're not really seeing very convincing vascular proliferation. So some of the hallmarks of glioblastoma that we saw on our prior case, we don't really have that yet. So we do look around, we see that there are some mitotic figures. There's an example of one right here on a very high power image. So there's mitotic activity, but the classic features of glioblastoma are not evident. So, however, we're dealing with an infiltrating glioma in a patient in his 60s. So that is that's a concerning finding, poor prognostic sign. And this one, it's mitotically active. We would presume it to be a bad actor, particularly if we can find that there is no evidence of an IDH mutation. So immunohistochemistry for IDH1 was negative. So we really have a lot of information. Just in the not too distant past, we would have been able to say anaplastic astrocytoma for this, or anaplastic astrocytoma IDH wild type. And that would have been a diagnosis that we could have handed off to our colleagues, and that would have given a defined treatment regimen for the patient. In the context of the 2021 CNS WHO, but with glioblastoma being a more coherent or defined molecular lesion, we now have to go and search for a molecular finding to define this as a glioblastoma. So I'll walk you through how we would do that. Basically, what we're going to be looking for is some of those cardinal features I was mentioning in the prior case: EGFR amplification, combined whole chromosome gain of 7, loss of 10, or a mutation in the TERT promoter gene that you could assess via sequencing, for instance. Diffuse or anaplastic astrocytoma is no longer a WHO term. So a little bit more challenging of a circumstance from a diagnostic standpoint in terms of reaching that WHO diagnosis. But there's a little bit of an open question, okay, in this circumstance, particularly given variable contexts of how people practice. Okay, we still know this is a bad tumor. It's a bad circumstance. So, but let's walk through how we would arrive at this more specific diagnosis. We would, in our context, run a chromosomal microarray, and this in this case actually shows polyploidy. This is a polyploid tumor, so there's a whole genome gain of chromosomal material, so that the normal here is actually more like 3 copies of most of these chromosomes. And in context of that new normal 3 copies, we can see that there is again a loss of chromosome 10, a gain of chromosome 7, and it's a little hard to see here, but there was another amplification of EGFR in this case. So we have our gain of 7, loss of 10, EGFR amplification. We have the features that we would need to make a diagnosis of glioblastoma. And that was the diagnosis in this case. It's an interesting circumstance for me, because it's, the molecular findings are key for the diagnosis here, but even without the complete molecular profile, this tumor would have been suspected to show poor behavior. We knew that IDH wild type anaplastic astrocytomas were bad tumors, and in a lot of cases behaved a lot like glioblastoma, right? It's just that now we define them as glioblastoma because we look, in many cases, we go and look and find these cardinal molecular features. But from a very practical standpoint, one could feel comfortable diagnosing this as a high-grade glioma, particularly as long as you had your IDH status in hand. You knew it was IDH wild type, or most likely IDH wild type in the circumstance of running the immunohistochemical stain. So we would have known this is a bad tumor. Patient's age, imaging characteristics, morphology, and then we would have seen that IDH immunostain was negative. So in this circumstance, you would know it's a high-grade glioma, regardless of whether you went and chased all of the findings that you would necessarily need to make the term formally glioblastoma. I shouldn't minimize the importance of looking for that, that formal diagnosis, particularly for patients who are looking for clinical trials or something along those lines. It can be extremely important, but it's I think in the current context where there is just this wide variability in testing approaches and in availability of some of the testing, the reality is that sometimes you're just going to have to be able to state high-grade glioma and then move from there. So the third case is a younger patient, also with a frontal mass. I didn't purposefully select all these cases as being from the frontal lobe, but here we are. It's also presenting with headache and nausea and vomiting. And here we have a low power image showing us some hypercellular brain that is involved by tumor with two distinct components. We can see here in the center, it's still hypercellular, but we can see a fair amount of that pink background, that pink neuropil background we can still make out from this power. But then at the periphery, hopefully you can see that it's quite cellular, becoming very blue here at the periphery. So we're really not seeing so much of that pink background. It's much more blue. So the first area with that pink background looks more conventionally like an infiltrating glioma. We can see the processes, the background processes. They're splayed apart. It's fairly edematous. And then we can see, well, what's causing this edema? What's causing the splaying of these background processes? Well, there's a tumor here. And a lot of these tumor cells do show rounded nuclear morphology. And some of them have a bit more of an astrocytic appearance in terms of having, you know, that plump pink cytoplasm, but looks like an infiltrating glioma. That bluer, more cellular component that we were looking at low power has more of an embryonal appearance. Very, very cellular, densely packed nuclei, a little bit of nuclear molding here, and not so much of the appearance of that pink cytoplasm, the more astrocytic or glial differentiation. So more poorly differentiated embryonal appearance. And then, you know, there was an area in this tumor where you could see the two areas intermingling with one another, where over here you have more of those infiltrating glioma type cells, and then over here on the left side, you see that there's more of the poorly differentiated, undifferentiated embryonal type component. So let's do some immunostains. We'll run our typical glioma panel, and we found that there is IDH1 immunoreactivity. You can see that some of our astrocytic tumor cells are nicely expressing IDH1, strongly so. But then even in some of our more embryonal or primitive appearing cells, they also have some brown staining in their cytoplasms. So both components have IDH mutations. ATRX immunohistochemistry, of course, this shows the quote unquote positive result is loss of expression. So here we see that both the glial and the embryonal components of the tumor show loss of expression. The intact cells in the background are normal background glial cells. We can see that there's some staining in some of our endothelial cells as well. But basically, we can see that there's loss of expression in the tumor cells. And then by contrast with p53 staining, we see that there's overexpression in our tumor cells, with some of those background cells showing much less expression. So the suggestion here, we have an IDH mutant tumor that has an ATRX alteration and is probably TP53 mutant. So you can diagnose this at this point as an IDH mutant astrocytoma. And with the morphology, you could get a pretty good idea that what this is an IDH mutant astrocytoma with a primitive or embryonal appearing component. And this is a known thing in gliomas that sometimes they have, the old term was GBM-PNET, now is primitive neuronal component, where IDH mutant astrocytomas can do this as well, where this is an IDH mutant astrocytoma with a primitive neuronal component. And we'll go through some of the molecular findings that we did do a workup on this case, but in a lot from a practical standpoint, the molecular findings are largely confirmatory or illustrative at this in this circumstance. So what did we find? A lot of those primitive neuronal components have MYC or NMYC amplifications, and this is what we did find in this circumstance. This is just chromosome 2 that we're looking at. That's where MYC-N is located. And so this is most of chromosome 2 is normal, but here is an area where there is a substantial gain at this location in the copy number probes, and our smooth signal shows a very much of a spike at that spot. And looking carefully, we would see that MYC-N was in that spot. So this is a MYC-N amplification. And then we saw that also there was a phenomenon called chromothripsis in this tumor, where we saw in chromosome 11, actually, there was an area that was extraordinarily complex with lots of gains and losses involving almost or basically the entirety of 11q. And within that context, there was a cyclin D1 or CCND1 amplification in this tumor that we then went and stained for cyclin D1 by immunohistochemistry and showed that the cyclin D1 was mostly overexpressed in the embryonal or primitive type component. So we basically were able to tease apart that this was an astrocytoma that was IDH mutant with a primitive neuronal component that was associated with several different genetic alterations, including cyclin D1 amplification and overexpression. Now, it's very important to recognize the presence of that primitive neuronal component. There are studies that indicate that those components have a propensity to spread via the CSF, but the diagnosis in this case can really be made by morphologic examination along with immunohistochemistry. It was a fascinating thing and academically very stimulating to go through the entire genetics in this case. Really, morphology was the foundation of the diagnosis. So for case 4, this is a younger gentleman with mass in the temporal lobe. We did not go with the frontal lobe, so this is a temporal lobe mass. And here again, we see a very, very densely cellular tumor. Basically no normal brain that we can see in this image. And we're starting to get the impression that there are some cells here that are quite large, quite aberrant in appearance. And on higher power, we can see that there are many, many mitotic figures, including some atypical mitotic figures. So marked atypia, numerous mitotic figures. This is a really aggressive looking tumor. Now, we did our glioma panel on this case. IDH was negative, but ATRX, interestingly, showed some loss, some reduction in staining in the tumor cells, whereas again, the cells that are a little bit more convincingly, strongly brown are actually smaller cells that are in the background. So the larger cells show a very faint staining, suggestive of a reduction or potentially a partial alteration. P53 was through the roof. Visible from, just looking at the slide without the microscope. So very suggestive of a TP53 mutation. This is again a densely cellular, poorly differentiated or undifferentiated neoplasm. We have concern for an embryonal neoplasm. This is a younger person. So there are, of course, embryonal tumors in general, more common in younger people. We do know that supratentorial tumors with an embryonal tumor appearance can represent a variety of different tumor types. However, in this circumstance, with the alterations in ATRX and the suggestion of a TP53 alteration, it prompts consideration, again, of one of those IDH mutant tumors or potentially an H3 mutant tumor. Now, our IDH1 immunostains were negative. That makes an IDH mutant tumor less likely. However, of course, you could consider one of the IDH mutations that's not addressed by the immunostain. So, but what about those H3 mutant tumors? We haven't talked a lot about those just yet. So, two main types of these. One of them is the diffuse midline glioma, usually seen in the midline. In children, less commonly, you can see them in adults. We see them a few times a year. These can be detected by immunohistochemistry for the K27N, the mutation-specific IHC, and then loss of expression of H3 K27ME3. So those two stains are really helpful for those diffuse midline gliomas. This case, though, not in the midline, so it was negative for those two immunostains, but really would have been a surprise if it had been turned out positive. So the diffuse hemispheric gliomas, though, they are found more out in the cerebral hemispheres, and they can show an embryonal-like morphology. So in cases of CNS PNET, CNS primitive neuroectodermal tumor that were diagnosed in the past, studies of those have shown that quite a few of them are actually these diffuse hemispheric gliomas. They can often show ATRX mutations or loss, and they can often show TP53 mutations. And then GFAP can be sort of wishy-washy. It could be positive, maybe not positive, and particularly in the embryonal-like areas of these tumors. Importantly, OLIG2 is usually negative in them. So a lot of gliomas will express OLIG2, a lot of diffuse gliomas in particular, and the IDH mutant tumors among those will be oftentimes OLIG2 positive. So OLIG2 can kind of help you suss out whether this could be potentially an IDH mutant tumor or not. So let's bring it back to this case. ATRX and P53 are a part of our standard workup on every glioma. Looking for those mutant patterns, particularly when IDH is negative, can really help prompt consideration of some of these unique or uncommon entities, like the H3 G34 mutant tumors. Another one to mention would be H-gaps, or high-grade gliomas with pyloid features. These are tumors that sometimes can have ATRX alterations, for instance. So GFAP was positive in this case. OLIG2, as I mentioned, can be extremely helpful in this circumstance. We actually didn't have OLIG2 IHC when we were working this case up originally, but the histology, clinical pathologic setting, and IHC results really suggested an H3 G34 mutant tumor. We did need to do sequencing for the mutations in order to confirm the diagnosis, but we had a pretty good sense of what we were dealing with just based upon clinical pathologic circumstance and the IHC and morphology that we had. So in this case, the diagnosis was diffuse hemispheric glioma, H3 G34 mutant, CNS WHO grade 4. And again, with the morphology and IHC, a diagnosis of high-grade glioma could be attained in this case. This made me think a lot about how, in my neuropathology training, I had a senior attending tell me that tumors with this morphology were once called PNET if the patient was a child, and glioblastoma if the patient was an adult. And that it just makes me think about how, as we go through the process of molecularly working up so many of these entities, it gives a lot of new context to those old axioms. It's really, sometimes the molecular features really give a little bit of a new understanding of some things that we frankly have known or have suspected based upon the practices and knowledge of the past. So In summary, the practice of surgical neuropathology involves the management of multiple data streams, clinical, radiographic, morphologic, genomic. And you have to understand how to weave all those together in order to make a diagnosis. Morphologic analysis, further buttressed by immunohistochemistry, remains an essential component of a neuropathologic workup. We're pathologists. It's still a critical aspect of what we do. And practicing with incomplete data, really something that all physicians must be able to do. Unfortunately, we're all human. We're all limited in terms of our ability to know everything. And we, as physicians, we are required to make decisions that guide patient care while minimizing any potential harm in a circumstance where we do not have all the information to hand. So that's just that is clinical practice from my perspective. So there are our lecture objectives. Hopefully we've attained them. I really appreciate this opportunity. Again, it's been a lot of fun thinking through this, and really appreciate the opportunity. I thank you again very much. This is just an image of downtown Atlanta. Atlanta is a city in the southeastern United States. It's a very warm a lot of the time. It's also the city of trees, or city in a forest is one of the ways that it gets mentioned. And that's just because there are a lot of trees. We basically are in an area where there's a lot of forest cover. And so if you go up into one of these buildings in downtown Atlanta, for instance, this is the Peachtree Plaza over here, has a restaurant at the very top. And you can get in and look out, and what you'll see is a blanket of trees where you know there's a city hiding underneath it. But in most of it is actually tree covered. So again, thank you so much, and I really appreciate this opportunity.
Hello. Okay, thank you so much for all the speakers. Yeah, hey Stuart, how are you?
Doing great. How are you? Can you hear me?
Yeah. So thank you so much for the presentation. It was very nice and educational. I'm still waiting on Dr. Raza to be online. So let's start shooting the questions towards you. So I currently don't practice neuropathology, but I have few questions from the audience. Most of them are offsite, online. So we will start point by point. How about that?
Sounds fabulous.
Okay, so I will start with the most recent one. So if ID8 is wild type in a radiologically diffuse glioma of histological grade 2, further testing for TERT and EGFR is negative, and additional testing is not available. What, in your opinion, should be the best course of action? Should it be treated as high-grade glioma or grade 2 glioma?
That's a very good question. From my perspective, one of the key questions here is going to come down to what's the patient's age. If it is a diffuse glioma that is histologically grade 2 in someone who is, say, 70, I would be very concerned about that, regardless of whether you can detect a TERT mutation or some of the cardinal molecular features of glioblastoma. There's some papers out there, interestingly, on some histologic grade 2 gliomas that only have TERT, but don't have the other molecular features of glioblastoma that don't always behave exactly like a GBM. So there's still a lot left from my perspective, to tease out the margins of what exactly all this testing means. But in that circumstance, I would really fall back on my clinical impression, which is if this patient is older, and we know that gliomas in older adults are usually bad, I would have treated as a higher grade glioma. In a younger patient, I would have a careful conversation with the neuro-oncologists, radiation oncologists, and see if they could even discuss with the patient what the circumstance is and decide, do you want to watch? You know, it's reasonable in that circumstance where there is some possibility, particularly given the lack of the cardinal features of GBM, where you're wondering, okay, is this something that's a really unusual type of tumor? There are certainly diffuse gliomas that have just single mutations, or things like BRAF mutations or other MAP kinase mutations that really fall into a very low grade category of tumor. And even though histologically they may appear grade 2, they sometimes get they're currently in the WHO slotted as no no WHO grade. And so I would be worried in a younger patient that I was actually dealing with something like that, where I just don't know that cardinal molecular feature, the MAP kinase alteration or something along those lines. So I would consider more strongly in that circumstance watching and waiting, seeing what the thing does, particularly if
So,
the patient's stable.
yeah, thank you.
Mhm.
Okay, the next question is regarding the ATRX immunostains. You know, for most of the times we see that if it's either lost expression or intact expression, but there is a difficulty when ATRX shows low expression, just like you showed in your case number 3. So this might be due to suboptimal fixation of the tissue. What are your thoughts about it?
The key with interpreting ATRX immunohistochemistry is being able to find cells that you feel comfortable and confident are normal background cells. And in my experience, there's really a couple of different circumstances with that immunostain that make it tricky. One is that it's just very sensitive to tissue fixation. If there is an area of the tissue that's just not well preserved, maybe it's cauterized a little bit, just a little bit, or is just not fixed well, the stain won't work. It will be all negative. And then there are cases where yeah, exactly, it doesn't stain quite as well. And in that circumstance, the key part for me is I would look carefully and see, okay, do I have endothelial cells? Do I have neurons? Do I have background glia that appear strongly intact? And hence my tumor cells are perhaps reduced, so I can see a differential between the two. And that's the way I report that circumstance, is reduced ATRX expression. I would be careful about, regardless, in the case of a reduced ATRX expression, I would look at my P53 stain. You know, ideally that's also going to be overexpressed, and you're thinking, okay, this kind of fits. And then of course, if IDH is positive, then you feel very confident that, okay, I've got IDH positive, P53 overexpressing, and then this ATRX is just reduced. It's not quite the classic circumstance.
That makes sense. Thank you. Okay,
Mhm.
the next question is, how often do you need to do molecular testing, you know, CDKN2A28 mutations for diagnosis of high-grade glioma? Or do you find immunohistochemistry sufficient?
For P16 testing, that is something that we look carefully at our microarray for. That's really something we rely on the genetics for. And it's helpful that a lot of the time that's not something that is determinative for grading. Obviously, with an IDH wild type glioblastoma, you can see homozygous loss of CDKN2A pretty frequently, but that doesn't necessarily impact the diagnosis. It doesn't impact the treatment or grading of the lesion. For IDH mutant tumors, of course, it's with the astrocytomas, it's very important. With oligos, it's helpful to know if it has a homozygous CDKN2A, but it's not that frequent that you actually detect it, and usually you're going to detect it alongside other high-grade features. It's not that frequent in my experience that something that looks WHO grade 2 and is an IDH mutant astrocytoma has a CDKN2A homozygous loss out of the blue. So we have some unpublished data where we did P16 IHCs on some on IDH mutant gliomas, and it's pretty tricky. It's pretty tricky to interpret. I wouldn't rely on it. And I think that the published data out there fits along with that with that thought.
Thank you. How often do you see the histological variants of glioblastoma?
Well, it's sometimes for me, I'm a little bit regretful that multiforme was dropped off of the name because they really can appear with a lot of different looks in the same tumor pretty frequently. And I know the WHO has still lists giant cell features, gliosarcoma, the PNETs or the primitive neuronal components as we described in this talk. Those, the WHO specific histologic subtypes, that's still infrequent, maybe 5% of cases overall, with gliosarcoma, in my experience, probably being the most common of them. But when you take glioblastomas as a whole, a large number of them have unusual parts to them, myxoid areas. Sometimes, in my experience, those myxoid areas can really elicit a strong inflammatory response, even neutrophilic response. It makes you start thinking, am I dealing with an abscess? It's a tricky diagnosis, no doubt. Even though there's so many of them, they can look a lot of different ways.
Yeah. Okay. Thank you. Last question, Stuart. Do you have a separate NGS panel for gliomas? If yes, then what mutations do you offer?
We run an NGS panel that is a pan solid tumor panel, and when we were putting this panel together, our molecular pathologists asked us for what mutations we wanted covered, and fortunately, some of those overlap with things that other areas of pathology want. So things like TP53, things like CDKN2A and B, and a TERT. That's very much something that you would run across in a number of different cancer types. For us, obviously, good coverage of IDH1 and IDH2 was critical. The histone the histone genes, H3, K27, so forth. Those were really important to cover. Really, the things that we wanted to rely upon for diagnosis. That was the thing that we knew we needed. We did include some of the genes that are important for things like meningiomas. So we didn't cover meningiomas in this talk, but NF2 is on that panel. And then there are a number of the less common driver genes for meningiomas, things like SMO, KLF4, AKT, that we did include, and part of that was because of a clinical trial that we're playing a part in, where if we find one of the less common drivers for a meningioma, that those patients may qualify for targeted therapy in some circumstances as a part of this trial. So we wanted to be sure that we could cover all of the most typical driver genes for meningioma.
That's thanks
so
to
forth.
Brad, right?
What's that?
Thanks to Brad for that, right? You're
Oh, yeah, we really rely on our molecular pathologists. There's there's a lot of interaction that our molecular fellows and the molecular pathologists, we've been very fortunate over the years that they've listened to us.
Okay, thank you so much, Stuart. It had been very educational, and I think the audience really learned a lot from you today. Um, it's really good to see you. You still have that boyish charm to you, you know, still look young. So
Well,
that's
thank you very much.
so we would in future I would request you to be part of our symposium if you have time. Maybe attend a symposium in person as well, if given an opportunity, like we discussed the other day. So yeah, you had some time crunch and time lag between the flights and everything. So yeah, thank you so much. Appreciate your talk, and it was really amazing to have you as a speaker.
It was a wonderful opportunity and very much my honor. Thank you so much, and I appreciate everyone's attendance and attention.
Thank you so much. Take care. Take care. Have a good day.
Bye-bye.
Okay, rest of the audience, we will finish the session. Dr. Raza did not join for QA session. So we will call it a day, and tomorrow at 11:50, we will have our first lecture. So until then, take care, and I will see you tomorrow. Take care. Bye.